and we are here from Gujarat chapter to be with all of you. And we have very two good and very eminent faculties as moderators for this particular function. And I really call it a function because it's not just a small 1 hour program, it is a 3 hour continuous session. And Dr. Girija Wagh will be moderating the first panel, which is on post-ART pregnancies, a very challenging area nowadays with COVID in the picture. And the second panel is, of course, of the most dynamic area of molecular biology and endocrinology, and that is gonadotrophins in ART. And that will be moderated by Dr. Seema Pandey, who is also one of our executive committee members at the National ISAR, and she's a very active gynecologist who deals with fertility problems, and she is here with us. And therefore, I welcome you all. Dr. R.G. Patel is the president-elect of Gujarat chapter of ISAR. He's a good friend and a very dear colleague of mine, and he had some assignments, but he did drop them, and he actually agreed for this commitment which he had made, and he is still with us. So we are very happy to have him. Unfortunately, Dr. Naina Patel had to drop out and she will not be coming, but we have another faculty in her place. I also invite all others who have to join us in the panel. And we have Dr. Gayatri Thakur, who is also one of the panelists for the first panel on pregnancy post-ART. Dr. Gayatri is from Jamnagar, and she is a senior specialist from Saurashtra in ART. And then, of course, we have the other panelists, Dr. P.K. Dheer, Dr. Pavan Dheer, who is from Bharuch. He is also a very senior member of ISAR, and he has been the past president of SOGOG as well. In fact, he was my predecessor to SOGOG presidency in 2006, and then I took over in 2007 for the All Gujarat Gynecologist as president. So Dr. Dheer is also very active in ART, and we have him here today. We also have the other eminent very top academician, Dr. Chaitanya Nagori, who actually has been one of my teachers in the past, and I revere him, and I'm extremely thankful to him to be present in this particular great meeting where a lot of deliberations will take place. I welcome Dr. Avandana Amin as well, who is from Ahmedabad, who is also an eminent ART specialist. Of course, Dr. Pallavi Satarkar is from Ahmedabad as well, and we have an active specialist who will be talking on various subjects in this particular field, and we will be deliberating on these topics. Dr. Kajal Mangukia is an upcoming budding gynecologist from Surat, and she is active into ART, and she is with us. She is the secretary of Surat Obstetrics and Gynecological Society. Dr. Sheetal Punjabi is our treasurer for Gujarat chapter of ISAR. Again, a dynamic young lady, gynecologist running 2 IVF centers in Ahmedabad. And of course, Dr. Sonal Panchal. Dr. Sonal is, we all know, a very eminent imaging specialist in gynecology. And in fact, I really wanted her to be on this panel because we are going to deal with pregnancy post-ART, where she has done a lot of imaging, and she will be giving us she'll be throwing a lot of light on this particular area. And I cannot forget Girija. Girija is one of my very old colleagues. We have been meeting very often in the conferences, I think for decades together. And she is from Pune, a very eminent gynecologist of Pune, very, very active. And she has been a teacher also at the Bharati Vidyapith Medical College, and a very eminent name in the field of gynecology from Pune as well as from Maharashtra. So we have a gamut of specialists who are going to attend. Dr. Sejal Nayak is another active member whom I have invited on this panel. She is also a budding ART specialist from Surat. She is very active in endoscopic surgery and fertility enhancing surgery from Surat, and she is also an executive committee member of Gujarat chapter of ISAR. I cannot forget the two very senior members who may not be present today, but one of them, of course, is our president, Dr. Prakash Trivedi, the president of ISAR, who is heading the organization, who is at the helm of all the affairs. And I must congratulate him for carrying this organization during the most trying times ever seen in this country, or maybe in the world, on this planet, for our lifetime, because we all know that COVID is something which has created havoc, catastrophic consequences, lot of disabilities, death and destruction, and economic, absolutely economically, it has driven out a lot of problems, created a lot of problems. But here we have ISAR still existing, ISAR still working on the virtual platform. Dr. Kedar Ganla is a very active secretary at the national level. He integrates a lot of programs. He is also a young budding ART specialist. And I hope I have covered everyone, and I have not missed out on anybody. And if at all I have missed out, my apologies, because I think we should be starting with this program as soon as possible. So let us go ahead with this program. I thank you all for joining at this time.
Thank you so much, Dr. Nimish, for such a warm welcome. So from MCure side, I would like to welcome each and everyone for joining this webinar today. My name is Komal Kanadia, working as a brand manager with Kaiwa, a division of MCure. We have Dr. Amit Borse with us, marketing manager. Then we have Kishore Mule with us, who is heading a BDM for Gujarat. Then we have Nikhil Mehra sir, who have joined us as sales head. So Nikhil sir, would you like to say a few words before just starting the webinar?
Sure. Thank you so much, Komal, for handing over. A very warm good evening to everyone. I am Nikhil Mehra. On behalf of MCure, we are very happy to have this event today. I am heading a division of MCure Kaiwa, which is mainly deals into fertility management. We would like to take this opportunity to thank Central ISAR, Gujarat ISAR, all the panelists, moderators, and delegates out over here. Very happy to see the vibrant speakers today. I'll not take much time. I'll just quickly tell you a glimpse about MCure. So I'm sure doctors, you all know that MCure is a global pharmaceutical organization. We have presence with over 70 countries worldwide. And when we talk about India, we are ranked as top 12 pharmaceutical company in India and #1 in the field of gynecologicals. Moreover, we are the most preferred partner in the field of infertility management. On behalf of MCure, we will be really looking for more such scientific event with each one of you. Thank you very much. Handing over to you, Kumar.
Thank you so much, sir, for your words. So now, before just starting the webinar, I would like to give a very short introduction of Dr. Nimish, as he has already introduced everyone, although he don't need any introduction as such, but would like to just give a very brief introduction. So Dr. Nimish right now heading Gujarat ISAR as president. He has also been vice president of FOXI 2003, president SOGO, and also honorable clinical secretary ISAR 2006 and 8. He is a pioneer in IVF and ART in Gujarat with several landmarks and first of their kind in IVF, ICSI, cryo, blastocyst births over a decade. So also chairman FOXI committee on reproductive endocrinology, Asian pioneer of salpingoscopy since 1992 with clinical research fellowship under Professor Ivo Brusins, Belgium, scientific director, Gujarat Institute of Reproductive Medicine and Research, governing counseling member to India College of Obs and Gynae, leading FOXI officer, bearer representative to FIGO General Assembly, FIGO World Congress, Santiago, Chile, national advisor to FIGO, diplomat and fellow European Board of Microsurgery, Belgium, founder Indian Society for Assisted Reproductive, Indian Academy of Juvenile and Adolescent Gynec Ops, diplomat and ICOG foreign fellow, Kiel School of Gynecological Endoscopy, Germany, recipient of over 45 national and international awards, including over 10 awards from FOXI as the youngest postgraduate till to date, Indian College of Ops and Gynae's foreign fellowship. So there are a lot of different achievements that he is also having. Also, he has also been chairman 7th National Congress on Juvenile and Adolescents Gynae 2000 founder fellow, Indian Academy, in charge vice president FOXI World Congress on Population, in convener Yuva FOXI, West Zone, established FOXI or NIMISHR. Doctor, a very warm welcome from MCure side, and would like to just hand over the session to you. So now you can start the panel discussion and going forward. Dr. Nimish, over to you.
Thank you. Thank you for such a kind introduction. It's my great pleasure to, well, let us start with the first panel of this particular program. And I would invite Dr. Girija Wagh, who is the moderator, to start with the first panel, which is on pregnancy post-ART. Dr. Girija, please.
Sir, may we request you to introduce Dr. Girija ma'am once?
Yes, certainly. It is my pleasure again. I mean,
Thank you.
Dr. Girija Wagh is the professor of Department of Obstetrics and Gynecology at Bharati Vidyapith. I already mentioned that. She is senior consultant of Cloud9 and Apollo Hospitals, Pune. Faculty professor of OGASH, International Experts General Coordinator, Chairman of Medical Disorders in Pregnancy Committee of FOXI, Vice President of India Chapter Gestosis, member of the Governing Council of ICOG, joined National Secretary of FOXI in 2010, Assistant Coordinator of National Eclampsia Registry, member of the Central Supervisory Board of the PC-PNDT Act, and she's very active on that. National Mentor of Lakshya NPOQC in, Lakshya is, most of you must be knowing, Lakshya is a drive to, go for maternity as well as certain SOPs, which standard operating procedures for maternity, healthcare, and delivering babies, and also having proper labor outcomes. And Anandibai Joshi Award for Excellence in Medical Services. So we have a very eminent faculty here. We are proud to have her, and she is from National ISAR, representing the National ISAR. So this is a very delightful joint program between the center as well as Gujarat State. So let us have Dr. Girija Wagh to start this panel.
Thank you so much for that wonderful introduction, and thank you for this opportunity of being here, trying to get into understanding as to whether the pregnancy management after ART has to be a special focus or it has to be different. And I'm so very grateful to the MCure and the ISAR for getting me here as a moderator today. Dr. Seema Pandey and I have been doing these sessions now. This is the third session in tow, and it's nice to be here on this forum. And especially MCure for creating their Materna School of ART. Dr. Prakash Trivedi, Dr. Kedar Gandla, Dr. Nimish Selat sir. I wish Dr. Dharmesh Kapadia a good recovery for his mother. And the panelists, and I have been told, Kedar told me that the Gujarat panelists are going to be very, very, very eminent, very efficient, and they have been such pathfinders in the practice of ART and the prenatal care. Dr. Vandana Amin, Dr. Palwati Satarkar, Gayatri is my very dear friend, Sheetal Punjabi, Kajal Mangalurkar, and of course Sonal Panchal madam. More than, I'm looking forward to an opportunity of learning a lot of things from her. Now, as I would like to start with a quote by Germany Kent, live your life in such a way that you'll be remembered for your kindness, compassion, fairness, character, benevolence, and a force for good, who had much respect for life in general. And I think that's something that we have to try and achieve from the journey of your life. And we were looking, it's always inspiring to look at the biographs of people like Dr. Nimish Selat sir. You've been always an icon and an inspiration to us in many works. So while we are looking at multiple gestations achieved by IVF appear to have similar outcomes to those of multiple gestations conceived spontaneously, certain singleton pregnancies after IVF are associated with an increased incidence of complications. And there is an increasing evidence that infertility or subfertility is an independent risk factor for obstetrical complications and adverse perinatal outcomes, even without the addition of ART level 2. And this IVF is probably because attributed to the various kinds of handlings, that is probably the handling, aging, hormonal influences, background maternal and paternal health issues, surfaces, or many evidences exist comparable between the techniques of ART, and surrogacy can add some more fuel to the fire of this particular thinking process. Now, higher order of gestation has been a challenge. Perinatal risks that may be associated with ART and ovulation induction are much higher in multifetal gestations, and singletons achieved with ART and ovulation induction may be at a higher risk than singletons from naturally occurring pregnancies. However, it remains unclear to what extent these associations might be related to the underlying causes of infertility. By and by, mota, if you look at it, such as parental age, background maternal health risks, genetic risks, structural risks such as endometriosis, surgical repaired uterus, adenomyosis, cervical insufficiency seen evidence concerning the outcomes of pregnancy, delivery, and early childhood associated with being conceived by IVF and related procedures are now available. And you can see that in this particular study of about 2,641 women compared to 5,000 control group women, there was definitely an increased possibility of pregnancy complications, perinatal complications, and neonatal outcomes in these patients. So the objective of this particular session today is one, pre-pregnancy optimization is that essential screening through pregnancy, morbidities, preterm deliveries, aneuploidies, and breastfeeding issue. And the important task is to come out with a consensus of an appropriate prenatal protocol for IVF conceived pregnancies. Special pregnancies require special needs as they may not have probably next better option to have this baby. And therefore, I would like to present my first question to Dr. Vandana Amin. I'm sure that after conceiving your patients with assisted reproduction, you must be also taking care of them during pregnancy. And what have been the commonest challenges that you have encountered amongst your patients? If you can tell us, Dr. Vandana.
Hello, everybody.
Yes, you are audible, dear. Yeah.
Our apprehension, doctor and patients both, are mainly abortions, anomalies, LSCS, delayed development, NICU admission, gestational diabetes, multifetal pregnancy related complications, prematurity, and that's all.
Okay.
More?
So, and I'm sure that you must have appreciated that these are much on right. And yes, if you look at the various complications that have been studied, and this is from the largest study of IVF ART pregnancies, that is from the Belgium group, where they found that there was an incidence of OHSs, miscarriages, and ectopic pregnancies, which was quite a little common and significantly more. And I'm sure that we have, and this has been told to me by many colleagues like you, and even I practice ART, that we have been able to control the occurrence of OHSs much to an extent. However, we are also sometimes, I am also running a high risk obstetric unit. We do have some patients getting admitted in the HDU with OHSs, and the biggest challenge then is as to how are we going to, deal with these patients, especially when they become pregnant. So Dr. Pallavi, can you just tell us as to how have you been able to control OHSs in your practice?
Yeah, sorry, I was attending a call from post-op call from hospital. I'm
sorry,
really sorry.
Should I?
No, I'm absolutely sorry. There were initially some, but I'm very glad I'm able to be back here in time. So yeah, early OHSs, I think this is sometimes very common when these are those borderline PCO patients, when you do the embryo transfers where the AMH level is say borderline 4 or 4.5, where you get tempted and you go for a single blast transfer, and then you have those ovarian refills on both the sides, and then the extra HCG of the pregnancy is doing the damage. Now you want to retain back the pregnancy because it's a precious pregnancy. And so basically at that time we can withhold estradiol because it was a self-stimulated cycle in case if she was prescribed sildenafil. So anything that is going to make hypervascularity, increase the vascularity, so causing torsion and again complicating the current pregnancy, we would like to withdraw Delsprin and maybe add vaginal Capgolin twice daily. I like vaginal Capgolin has never been proven in incidence, but clinically yes. Practically sometimes the things are working better, which even does not have evidence-based backing up.
Yeah.
So I think that should do wonders. Yeah, that should control a lot.
I think she's given us a very important tip that sometimes things may go out of hand despite you taking adequate care. And then in that case, you can consider all these particular essentials, withdrawing estrogen and giving cabergoline. Thank you so much, Dr. Palvi. And this question is now coming to you, Dr. Gayatri. We all know that vaginal bleeding in the first trimester is quite distressing. It's a common complication with an incidence of 16 to 25%. And most common cause of vaginal bleeding in patients who are 10 to 20 weeks gestational age make up about 11% of cases. And this is why. Can you just, Dr. Gayatri, tell us that, do you think that this is a common association with ART pregnancies, and are there any specific measures that you take so that this wouldn't occur? Yes, Dr. Gayatri, can I have you here?
Thank you so much, Dr. Girija. And vaginal bleeding is often with this ART pregnancy, and it can be occur up to 34 weeks of gestation. And I think mostly it is because of the primary factor of infertility, maybe PID or maybe cervical or uterine factor or some other combination of factors. But if there is no pain, then the prognosis is always good. I used to treat it with investigations. We have to go for APLA, means BT, CT, PT, EPTT, plasma fibrinogen, and routine CBC, as well as CRP. And we have to rule out the infection by vaginal swab. And without waiting for the culture report, we have to start with the broad spectrum antibiotic, local high dose progesterone, systemic progesterone, IV antibiotic, and we have to give tocolytics also in first week, and rest, as well as hydration, proper hydration, fetal monitoring. And if the cervix is closed and singleton pregnancy, there is no need for further worrying. Prognosis is very good. If there is low hemoglobin or there is some other indication, we can give fresh blood, PCV also. So I think vaginal bleeding is not a worry if it is in a small quantity without pain. Prognosis is really good. If there is a associated pain, we can use Tosiban also, and everything is fine with high dose progesterone and sometimes injectable hydroxyprogesterone depot. Yeah.
Thank you so much, Dr. Gayatri, for bringing out certain points. We were actually focusing more on bleeding during the first trimester, but you also encompassed that would be in the later part, doesn't matter, but that's given us an insight. But I would like to move to Dr. Kajal, because there was a wonderful point that Dr. Gayatri came up with, which all of us need to pay attention, and that is infection. Because it many a times may not be subchorionic hemorrhage, Dr. Kajal, it can also be a PID or a cervicitis or something. Are you taking any measures to ensure that such a thing doesn't come in the way of conception? Or because looking at the very high incidence of miscarriages in Indian women compared to the globe, globally, if the incidence is between 15 to 11 to 15%, Indian women miscarry at the rate of about 25 to 30, and that's really a cause of concern. So how do you deal with this, Kajal, this specific aspect? Because I think that requires an important focus. Yeah.
Yes, madam. Good evening, everyone. Thank you, Dr. Girija, madam, and Dr. Nimesh Shelat, sir. And
you are looking very beautiful, huh? I must say that. I didn't compliment.
Ma'am, you are looking really beautiful.
Pink is favorite, Dr. Girija's favorite color.
Okay. Pink and blue combination. So yes, ma'am, coming to the question that PID is one of the commonest reason for vaginal bleeding during the first trimester. And the other aspect is that if there is a progesterone, if the patient is not taking regular medicine, even we do suggest that you take on a punctual time also. Timing is also very important. So to prevent the infection, generally what I do is that after the embryo transfer, I am giving oral antibiotics for 5 days. So,
Okay.
prophylaxis, what I feel is that prophylaxis is always better. Like prevention is better than cure. So that is a protocol which I follow. in my routine
Any
practice.
specific antibiotic that you consider giving, Dr. Kajal? Is there any particular choice post transfer?
I'm giving Zifi at present.
Okay, cefixime. So cefixime because of its safety.
Yes.
Madam,
Yeah, Dr.
Madam,
Pal-
Madam, can we take it that as such, there is no specific reason for as to why this bleeding happens?
Absolutely.
Yeah,
Yes.
yeah.
Basically, there is no specific reason, but looking at the challenges that we have to
Yeah.
have something to tell our patients and to
Yeah.
tell ourselves.
Yeah.
Patients know, hey, but when they are so trusting us that we need to tell ourselves. I'm going to ask question to Dr. Sonal, madam. And Dr. Sonal, because with her expertise of ultrasound, I can't help but talk to her about this. As to how do you, differentiate and tell us that सबकोरियनिक hemorrhage है भैया, लेकिन वो सब अच्छा चलने वाला है. What are your prognostication factors in the first trimester, which we can assure our patients on, Dr. Sonal, madam?
The very first thing we need to do is whenever we see any fluid surrounding the gestational sac or close to the gestational sac early in the pregnancy, the first thing is to exclude the possibility of the residual endometrial cavity still. Up to about 8 weeks of gestation, you often have a residual endometrial cavity. The endometrial cavity is totally not abated, and therefore you may see some fluid around. And this can be identified by following the fluid slit to the cervical, in continuity with the cervical canal. And if that is the case, it's less likely to be a subchorionic hemorrhage, and it's more likely to be a residual endometrial cavity. And in this cases, patient may present with some spotting or so, but these lesions, they disappear on their own without any support also within a period of say another 2 weeks. If it is a true subchorionic hemorrhage, and especially it is on the chorion frondosum side, so it's deep to the chorion on the opposite side of the cavity, that's when you're probably more worried. Subchorionic hemorrhages are a little more worrisome when especially they are on the fundal part as compared to the cervical region. So they are more worrisome when it is on the cephalic to the cavity as compared to when caudal to the cavity. And if the subchorionic hemorrhage is about 2/3, it covers about 2/3 of the length of the gestational sac, the chances of abortion are very high. If it's less than 1/3, the chances are less. But to be very specific, there is no definite criteria which can say this subchorionic hemorrhage will definitely not result into abortion, or this one will definitely result into abortion. Yes, it's true, less than 1/3 and in the cephalic part are safer as compared to the lower, in the caudal part, and less than 1/3 are safer as compared to the cephalic and more than 2/3 parts.
I'm sure the audience is taking notes like I am taking notes from you, and that's such a wonderful thing that you've given. Now henceforth I'll look at the sonography reports properly. So coming to Sheetal, now Sheetal has not yet answered any of our questions and not been part of this discussion. We know that it's probably a partial separation of the chorionic membranes from the uterine wall. And what are these conditions with which it is very commonly associated? Dr. Sheetal, can we have you? We want to hear your beautiful voice. Dr. Sheetal Punjabi. Is she there?
I had asked her to join, but she had also.
Okay, doesn't matter. So we go back to Vandana. Dr. Vandana, is also not here right now, but Pallavi. Okay, Vandana, you're there? Fine. So what are the risk factors beta of subchorionic hemorrhage, if you can just enumerate? I'm sorry I said beta, you look very young.
I'm sorry, will you please repeat?
The risk factors of subchorionic hemorrhage.
Subchorionic hemorrhage is mainly abortion, spontaneous abortion. Second, even after the subchorionic hemorrhage, I think it is it is not related to small preterm labor or small for
Yeah.
gestational age or IUD.
So, no, I was just coming to the risk factors of subchorionic hemorrhage, and as I must mention, yeah, we are coming to the risk factors also. What are the consequences? But presence of uterine malformations, history of RPL, and pelvic infections that we discussed are going to be the common ones. And yes, coming to the consequences. So as you mentioned rightly, that it may not always relate to occurrence of preterm labor or PROMs or early and late pregnancy loss. But then there are certain consequences, and this is something that the literature is a dilemma. Yeah, can you tell us? Yeah.
That includes preterm labor pain or PPROM or early pregnant or small for gestational age or increased chances of NSU pregnancy or delayed development in newborn, like that.
Yeah, and basically what we have seen is, in some studies they have shown there's a 5-fold or more increased risk of developing placental abruptions. So we will have to keep on catching Dr. Sonal madam all the time once you have such an occurrence, so that she will tell us much in earlier times if there is going to be such a possibility. And then we did look at the various treatments that the entire gamut of treatments Dr. Sonal did tell us. But Dr. Pallavi, would you want to add anything or modify anything that she has spoken about? Because both our other panelists did mention about antibiotics and progesterone in high dosages. Anything else in addition we should take care of when there is a subchorionic hemorrhage? Because, we have to finally disseminate knowledge and practical tips for our audience today.
No, I would like to just withdraw blood thinners if the patient is already on this, because that would add to unnecessary mess of bleeding, and I think that should be fine with a lot of progesterone.
Okay.
And yeah.
And in an RH negative mother, will you consider giving an anti-D?
Yeah.
You would want to give. What about tranexamic acid? Like, anybody of you has used tranexamic acid?
Yes.
Yeah.
We have used.
Yeah. So
But
I think
it is
all of
safe.
us, yeah,
It is safe.
there is no evidence, but we still use tranexamic acid because it does give us an assurance.
Is ethansilate fort a better molecule, or tranexamic acid is a better molecule?
I know.
Because then, I don't know, sometimes it feels like giving seal fort or tranexamic acid. But yes, whatever, like 3 times a day, maybe for 3 days, it does the trick. I mean, in maybe 2 days of doses, the patient is absolutely fine with the bleeding episode.
The challenge and the question that comes to our minds always is, we are still at the time when embryogenesis is occurring and placentation is occurring. And therefore, we are definitely not really confident as to what these medications are going to cause harm. But yes, sometimes we have to take recourse. These are usually our helpless moves that we undertake, despite knowing that maybe things are not really going to go so bad, things will come up, but we have to help the patients in some form. And progesterone has never been given a great kind of a support, more than 30 to 35% of success with in association in many small studies. But of late now, we have these 2 studies which have come up, and therefore we have an evidence backing up and telling us that yes, you can consider using progesterone. Like the PROMISE and the PRISM study. In PROMISE, where they studied 836 women with unexplained recurrent miscarriages at 45 hospitals in the UK and the Netherlands, and found a 3% higher live birth rate with progesterone. And in the PRISM study, 4,153 women with early pregnancy bleeding at 48 hospitals in the UK, and found there was a 5% increase in the number of babies born to those who were given progesterone, who had previously had 1 or more miscarriages, compared to those given a placebo. So we can still consider. What about HCG injections? Can any of the panelists tell us about HCG injections? Dr. Sonal madam, I'm targeting all sonography related questions to you, but you can please, you're free to comment on anything
clinical
that you feel worthwhile and want to add on. Yes. Yeah. So anybody?
HCG I am giving.
Okay.
Madam, I am also using HCG, but till the cardiac activity comes, then generally I stop the HCG injection.
Okay.
No, madam, my argument is, if there is a supporting cyst, ovarian corpus luteum cyst is not good, and I feel there is a not apparent volume of choriodecidual hemorrhage collection, and still there is a bleeding, then for supporting the receptor activity as well as to accelerate the autogenous placentogenesis, I used to combine HCG with progesterone. And one thing more I used to give is diazepam, 5 milligram at HS, which is time tested since my residency. We were taught to use in threatened abortion and all the recurrent pregnancy abortion where the prognosis is good. So I still today use diazepam at HS, 5 milligram tablet HS.
Okay.
And with antacid also, because to cool the bowels is very important. Without constipation and without hyperacidity state is very important. At least I feel that is my individual approach to a patient, that she should not have any other digestive problem, so that the immediately she can come out of the bleeding episode. So I will see that both the things also.
Okay, so
Can I add one small thing there related to sound, especially because we know that usually subchorionic hemorrhage when it's there and we are afraid of abortions. So I would just add this one small thing that up to 8 weeks of gestation, it's always essential that when you do a scan for the fetus or the embryo, that's when you'll always have to check the corpus luteal flow. And if the corpus luteal flow is low resistance flow, it means that the chances that the pregnancy will be supported well endogenously.
HCG, yeah.
I'll not add anything about HCG or progesterone. That's not my field, but yeah, I thought this may relate to your supplementation of HCG or progesterone.
Thank you so much. Yeah, because corpus luteum function was my next question for you, and you answered it, and you knew, so you understand me so well. Is something that I must So there has been a Cochrane review which has mentioned about progesterone for preventing miscarriage or network meta-analysis, and they have mentioned that there is still uncertainty over the effectiveness and safety of alternative progesterone treatments for threatened and recurrent miscarriages. Now, another problem that we come across is, this is to Dr. Kajal, if I may ask you, is, you may have a patient who you have done an assisted reproduction, and then you did a sonography and you found that it is a heterogeneous pregnancy. And this is another complication which we have to deal with. And you can see here in this particular picture that there is a ruptured corneal pregnancy which has been tackled, and then there is an intrauterine ongoing pregnancy. And on the right side bottom, you can see that this is a picture of the uterus at the time of cesarean section delivery, where you can see how this heterogeneous pregnancy was dealt with that time with a glue. Now, what are the various tips that you would give our audience, Dr. Kajal, as to ensure that what is happening for the good, and what will be your protocol to identify? Because these are happening. We all are knowing, we take a lot of utmost precautions at the time of embryo transfers. But then there are certain things which are within the uterus of the woman which are beyond our control. So how should you do surveillance and to ensure till the time that it's an intrauterine pregnancy? Can you tell us, Dr. Kajal? And then we are going to come to Sonal Madam again. Yes.
Generally, after the embryo transfer, I call patient after 2 weeks. On day 15, generally, I advise beta HCG. And then after 48 hours, if there is a doubling, then we prefer that it is an intrauterine pregnancy. And after generally 10 days, I call the patient to check for the transvaginal sonography. And if the beta HCG level is above 1000, then generally we should be able to see a gestational sac inside the uterine cavity. So that time we can confirm. And plus, we should always keep a heterogeneous pregnancy in mind. Like if we are confirming it is intrauterine, we have to rule out that if there is a extrauterine also, like we should check for the gestational sac outside the uterine cavity also.
Yeah. So you are using a protocol of doing at the HCG as the sonography and being very vigilant, and that's a wonderful thing that you told us. And we all have to know.
I want to share, ma'am, that my first patient, she had a heterogeneous pregnancy, and I still remember that patient. So the intrauterine pregnancy was kept, and the ectopic pregnancy was dealt with the surgery.
Okay, so you pushed it too hard, looks like. Huh? What did you do? True. So we have to be looking, as she rightly said, that the doubling time of intrauterine pregnancy, the serum beta HCG level rises 66% every 48 hours. If not 48, at least 72 hours, you repeat it and ensure that what's happening. And you have to consider, just don't get, many times sonologists and all of us also, the moment we see the fetal pole, we keep on looking at that and we don't look at the rest of the things. And therefore we may miss on what is an heterogeneous pregnancy. I have had some of my students sending me images where, you're confused whether it's a corneal disformation or there's some sort of a uterine deformation which is there, which is collected on hematometra or something like that, and whether it's an ectopic pregnancy or a heterogeneous pregnancy. So we are going to have Dr. Sonal Madam to give us an insight into some few tips, quick tips as to when we do these scans in the first trimester, after we have done the embryo transfer, what are the various things that we should see and be on guard about?
The first thing that we will do, the scan that you do to confirm that it's an intrauterine pregnancy, the first scan after you have got a positive beta HCG, of course, the discriminatory label and everything has already been mentioned in the previous question. But what you see is, one, the gestational sac is surrounded by the endometrial cavity, one on the longitudinal axis, in the longitudinal axis of the uterus, and it is eccentrically placed. When I say gestational sac, it is already conveyed that it has a typical decidual ring, and if it has yolk sac and just a fetal pole inside, it's even more confirmatory. So the true gestational sac is always eccentric. So you would see that one endometrial lip is more thicker than the other one, which tells you that it's probably an intrauterine gestational sac. Always rotate your probe 90-degree anticlockwise to see the transverse section, and confirm on the transverse section also that you are seeing the gestational sac well within the endometrial shadow. If you are seeing the gestational sac on one corner of the endometrial shadow, it's essential that you confirm that it's not in the corner when you scroll the probe across on the entire transverse axis. And if it appears like it's too much on the side, you must confirm that in no single plane you are seeing the gestational sac and seeing the endometrium covering only one side, and on the other side is the myometrium, which tells you it's probably an angular pregnancy. And it's also essential that you go right up to the fundus in the transverse plane and confirm that there is no gap, no myometrial gap between the lateral margin of the endometrial shadow and the medial margin of the gestational sac. If that is the case, it's an interstitial pregnancy. Of course, 3D is absolutely, it plays a very important role, because it definitely will confirm the position of the gestational sac. After that, follow the soft tissue adnexal band, go to the ovary. And when you do that, it is more likely that if at all, even if there is a small ectopic or a tubal pregnancy, extrauterine pregnancy can be easily picked up. So those are the things which will assure that it's an intrauterine pregnancy. To confirm it's live, you can put on a Doppler, but if you're seeing a fetal pole, you don't need to do that at all.
So thank you so much. I think they are very valuable tips that you have given us. And we dealt with the early pregnancy complications. Thank you, panelists, for your valuable inputs. Now we move on to the maternal complications that have been encountered in ART pregnancies, where we find that the pregnancy-induced hypertension and preeclampsia has a little high possibility in these patients. And now if you see in the recent guidelines of 2020, the ACOG has added assisted reproductive technology as one of the risks for preeclampsia in history itself. You don't even have to go in for surveillance, but this is what gestational diabetes is much on rise. And if you can see that as it is 30% of Indian women are suffering from GDM, but ART patients usually very commonly have this problem. And venous thromboembolism is another thing. A lot of, we are not very closely looking at this possibility, But now we are seeing, as the obesity is rising, as the IVF conceptions are rising, we can see, and sedentary lifestyle is rising, we can see that VTE is quite common. So any of the panelists can take this. I would prefer Dr. Pallavi to tell me as to what would be your approach to this patient, taking into account the fact that preeclampsia, gestosis is going to be a problem in this patient of mine. So how do you go about trying to mitigate this particular risk in your patient?
Yeah, once we know that the likely patient who's prone for preeclampsia, supposedly it's like late maternal age or twin pregnancy, or so you have to have a protocol like a standard operating this thing, clinically markers, that is her measurement of weight, blood pressure, and when you start and the blood profile. That is, in the blood profile, you are going to have her all the routine investigations of the entire blood count and LFTs, the entire coagulation profile. Because even sometimes what happens is you have done the pickup 5 months, then it was a frozen embryo transfer cycle. So as soon as the patient has conceived and you have having a beta, you again have the pregnancy changing the physiology of the body again. So you have to again have a repeat baseline investigations, or baseline workup, blood work for the patient getting done. So you know her basic weight on positive beta HCG, then her blood pressure, any of the previous high readings, her age will give you what is happening, and then the soft markers and on ultrasound, and then you can keep measuring. But the main target is that blood pressure not shooting up more than 120, 80, maybe 86 or something for according to the age of the patient. And prophylactically, whether to add low dose aspirin, because already all these patients are on aspirin. So sometimes if they are not added, then maybe a low dose aspirin, that would be a prophylactic thing in very early pregnancy. I mean, near, yeah. And maybe then when the patient reaches near the NT scan, say around about 13 weeks, then you can have the uterine artery markers and all those things setting in, which will give you more information as to where the patient is going.
Absolutely. So Kajal, do you have made any change in looking at the blood pressure measurements in your antenatal patients? Like, what is your policy of, in a regular antenatal mother, she's become pregnant, has come to you, ART or otherwise, and now what is your blood pressure management policy? Because all of us are trying to do something better, because we want to identify these complications as early as possible. And I think since most of us are giving LMWH, Ecosprin, sometimes there can be masking of the disorder to an extent, because we are doing a lot of prophylactic things for this patient. So Kajal, can you just tell us, have you made any policy? Is there any, or whatever practice, it's policy in the
GPCR.
Whatever we do is our practice,
Yeah.
Ma'am, the baseline blood pressure is very important. Like before we start the cycle or before the embryo transfer, and if the change in the blood pressure is mean arterial pressure, like more than 20 millimeter of mercury, then we say, like, the chances of this patient going into PIH is very high. Even the this urine albumin, that is also earliest marker, and serum uric acid, the biochemical marker which generally I advise is serum uric acid. So that is the earliest which we can come to know. I'm sure like uterine artery, PI and everything is there. But for me, blood pressure, proteinuria and serum uric acid.
Absolutely. So by the time your patient is getting, the moment she gets pregnant and you've confirmed an intrauterine pregnancy, I'm sure you must be looking at this particular parameter very carefully, looking at a very high incidence and association with ART. Dr. Sonal, if you can tell us about uterine artery pulsatility index, as a marker, because this has been come out as an important marker for Doppler surveillance of preeclampsia, and much of the fetal medicine has now jumped from aneuploidies to looking at preeclampsia screening in a big way. So I want your comment on what would be the right average for our Indian women as far as uterine artery PI is concerned.
Uterine artery PI, I mean, you can predict preeclampsia I mean, quite early now. It has shifted from the second trimester to the first trimester. The first screening is done along with the nuchal scan, and we always have to assess the uterine artery PI on both the sides, and we take a mean uterine artery PI. And in the first trimester, if it's more than 2.37, and you can, there are some studies which say 2.3, some says 2.5, but there are also studies with, so there are multiple values, but they're all between 2.3 to 2.5. And if it's more than that, that's when there is a higher risk. And they recommend that, I mean, this is usually done before 14 weeks, 13, 14 weeks. And if the uterine artery PI is high at that time, you can start, I mean, the study suggests you have to start 150 aspirin. If it is not done at that time and you're going to do it a little later, which means you have not done a first trimester screening or the first trimester screening, okay, you're going to proceed to the second trimester, and that's when you find that if the uterine artery PI, the mean uterine artery PI, is more than 1.3, and that is the stage when we would again want to add aspirin, because that is also a higher risk of preeclampsia.
Okay, so as Dr. Madam said that, you know, you have to keep on doing a continuous surveillance. So measuring blood pressure has been identified to be one very basic things. And thank you, Kajal, for enlightening us about what is very important is you use the right number, measure of cuff and the right technique to do it in the right position. And that is very important. And currently the FIGO initiative and the fetal medicine has also spoken about doing the mean arterial pressure, which can be done in both the arms. If you do not have the mercury manometer, you can use an Aneroid automated BP measurement and take a sort of an surveillance in both the arms and then take an average. And of course, if you are doing proteinuria, good, but if you don't find proteinuria and you have a patient at risk, it's always a good practice to do the protein creatinine ratio, which is another spot test. So that can be done when you find it is more than or equal to 30 milligrams per millimole in a singleton pregnancy, then that can tell you about microalbuminuria, and you'll have to be then on guard that this patient has a possibility of getting into genosis or a preeclampsia-like condition. And then, of course, serum uric acid was, you know, constantly going up and out and inside the preeclampsia panel, but today now it is again included. And the reason being, I must share with you this, Kajal, is that it is a sign of placental bed apoptosis, you know, that's been identified, and therefore it can be acting like a marker for abruption or any kind of placental issues, and that is of help. And of course, LDH is another parameter which can be used. So if you have a patient whose blood pressure measures 140/90, it's a good practice to do the profile and keep on temporizing her as much as you can. When we look at the biomarkers, I wanted to ask to my panelists here and Dr. Vandana, since we are looking at patients who are at high risk, of course, we are very blessed that we are in a place where we can have our IVF labs and we can do our sonography. We have an access to radiologists like Dr. Sonal Madam, who will be doing uterine artery PI for us. But not all of our colleagues have such an access, you know, and then sometimes we feel, should we rest on biomarkers? Like while we are doing the PAPE and the beta HCG, currently we are also considering doing PLGF. What is your opinion? Is anyone of you doing a PLGF also along with looking at the risk factor of these women? Anybody? So none of us here. Okay, none of the panelists here are doing. That's something which is just coming up, that let's do a PLGF in these patients around 12 to 13 weeks, and that's going to be called as a triple antigen test now, a triple biomarker test. So you have PAPE, you have beta HCG, you have uterine artery PI, and you have the PLGF, and that would help us in identifying risks. And of course, if the patient has been diagnosed later, the surveillance will continue. But then we can also consider doing split PLGF ratios and glycosylated fibronectin to identify which women would require to be delivered. And Dr. Sonal gave us a wonderful insight into the fact that you have to look at the uterine artery PI. And these are the ICU OG guidelines of 2018, which talks about the first trimester PI, second trimester PI, as well as the third trimester. In both the first and the second trimester, even transvaginal ultrasound can tell us as to what it is and how it is being taken. So these are simple guidelines which you can look at. I just wanted to ask you, Dr. Sonal, that here you are seeing that first trimester we are considering 2.35. on TS and TVS 3.10. While when we are going to the third trimester, we are looking at 1.17 as a cutoff. Why does this disparity is there? Can you just guide us?
You mean why is the value lower
Yeah.
in the trimester?
The third
Yeah.
trimester.
What is the
As
pathogen?
pregnancy advances, there is going to be a decrease in the resistance normally also.
Yeah.
In the uterine artery, and therefore as we progress into the pregnancy, I mean as the pregnancy advances, the lower cutoff is what is required, because the normal is lower, so the cutoff for the higher is also going to be lower.
Yeah, so that is what we have to understand, that
because of a lot
there
of placental drainage into of the blood.
Yeah. So that was the theoretical part. And these are the various risk factors. If you look at the maternal risk factors, the moderate risk factors, and the high risk factors. And as I mentioned here, the ACOG guideline 2020 recommends assisted reproduction technique as a risk factor for preeclampsia, and therefore we have to screen these women. And this is the Justosis score.
Yeah.
Which the India chapter Justosis has come up with, it is mellitus, obesity, multifetal pregnancy, hypertension in the previous pregnancy have been given score 2, and pre-gestational diabetes, chronic hypertension, mental disorders, inherited acquired thrombophilia, chronic kidney disease, APLA, other autoimmune disorders, and pregnancy with assisted reproduction with especially oocyte donation and surrogacy have been scored as 3. So this can help us in counseling our patients also, that, you know, you have this particular possibility. That is the reason why I'm going to put you through so many, you know, investigations, surveillance, so that we are able to deliver you in a optimum time as much as possible. And this score we felt is feasible in our Indian setup, is based on history by and large, and mean arterial pressure and emerging factors, is cost effective, and is giving a gradation to the scores. So this can help us in identifying these issues. And as we understand, we can then consider giving them aspirin. But additional to aspirin and calcium, which has been proved by the, all the RCTs, my friends here, do you make any change in the patient's dietary practices or general lifestyle practices, especially in ART pregnancy? I think I can target this question to Dr. Pallavi or Dr. Vandana, whoever would want to take it, because I have done this. So any one of you want to share your experience, that apart from just giving her calcium and then giving her low dose aspirin, would you also, do you make any difference to this patient's lifestyle? Because she's an, Dr. Kajal wants to answer this question. Fine. Yeah, Dr. Kajal.
Ma'am, basically the non-pharmacological management, especially in the diet, the high fiber diet and high protein diet, which is very important. It plays a very important role. Plus, generally, what I prefer is the protein supplement also.
Yeah.
So that is, these are the changes. Plus, if there is no like low-lying placenta is not there and feasible, then I would recommend for the basic exercise also to the patient. We have a physiotherapist who guides them differently for the first trimester, second trimester, and third trimester.
Yeah, Dr. Thakkar madam also wants to say something. Yes, Gayatri madam.
Yeah, thank you. If I will see on the ultra is a day more than 2 weeks deviation from of the head and body and abdominal gut diameter difference, growth difference. And another thing I will follow up with the, as the Kajal said, high protein diet, low salt and high calorie with plenty of liquids. And if after 10 days or 15 days in second scan, still it persists with the naturally this PI is high, then I will definitely add the labetalol half to start with half BID. And I will see again for the weight gain also. If there is a sudden weight gain of 3 kgs or 4 kgs in a month, that will definitely give me a signal, red signal for the prior of a indication for she will go for PET even without rise in the BP. So these are the 2 things, because I don't want to take any chance, and labetalol proved very good for preventing oligo in coming days, as well as preventing IUGR also. And on the aspirin and over the calcium, they are the very not giving result giving, but all the IUGR treatment, I will start with the high PI findings. The sometimes arginine and
because PI would
all
also be
these
a marker.
protein supplements.
Addition of micronutrients which come in a combined this thing.
Definitely,
For, magnesium
definitely.
and
All
D3.
IUGR, yeah, Palvi. Yeah, D3 and all
Magnesium.
micronutrients. And we have to visit, explain and counsel a patient that we need to compare and visit, means more frequent visit with ultrasound monitoring of the fetus.
Yeah,
it's
so
my protocol, Girija,
Yeah.
that I am very alert about the patient where I found a radiologist or 22nd week high PI.
Okay.
Or 18 to 22nd weeks, yeah.
So what I wanted to drive across was a message, and which Dr. Kajal and Dr. Pallavi as well as Dr. Gayatri helped me to, consolidate into the fact that we have to not only look at post-IVF, but all pregnant women with the fact, even if there are no randomized controlled studies, but we have to ensure that they're taking proper diet. There are no starvation spells because they tend to take diets sometimes, a lot of bad components of the diet, a lot of junk they take, that should be avoided. Secondly, trans fats have to be avoided. They have to rightfully be given exercise, and today there's evidence that high fiber diet, exercise during pregnancy, definitely reduces the possibility of preeclampsia and justosis in pregnancy. And additionally, Kajal, to you that protein, because most of the complications that Indian women suffer from is something like protein energy malnutrition, and today a lot of WHO and FIGO activities are concentrating and focusing on the fact that every pregnant woman should consume at least 1 gram per kg body weight of protein throughout pregnancy, and that would help us. And second thing which Dr. Gayatri told us is weight, very important, that we have to have a structured weight gain in these patients. And all of us, you mentioned that if a woman is already having hypertension or she develops non-proteinuric gestational hypertension, she has a risk of going into blood pressure complications, and we would have to look at her carefully. I want to go back to Dr. Sonal here once again, because there was a mention made of fetal growth restriction, and I know that this question is not there in my slide, but Dr. Kajol, Dr. Sonal, of late, a lot of fetal medicine specialists are seeing this, and I have started looking at this carefully, that in the first biometry, which comes at around 19 weeks of pregnancy, I look at the femur length of the baby. And I have found that if you use that as a parameter to convince your patients to take proper diet, we are going to be able to either catch the fetal growth restriction early or to try and avoid it. What is your take and guidance on this, Dr. Sonal?
I have not personally used it, but I think logically thinking, it does appear to be quite useful. And I think we need to do some structured studies on the same, because since if you're talking about IUGRs, it's head which is not going to be affected. Femur, though it is generally believed not to be affected, but proper nutrition is definitely going to improve the bone length. Abdomen, yes, of course, though is considered as the first part of the body, or the AC is the first measurement which is going to decrease in IUGR, but probably.
Yeah,
long bones may be useful and may pick up IUGRs earlier. I think that's a study. I mean, a proper structure study must be done on that. Probably we can do that.
It is actually believed that, that the baby starts to save the nutrition for the growth of the better parts, and it doesn't have time yet to talk about that abdomen doesn't get affected at around 18, 19 weeks.
Yes.
So yes. I think all of us should start observing this. And what I've started doing is that I also give patients L-arginine for that window period. Especially I've done a 12-week scan, there's a problem. And then I would also, if I find same problem at 16 weeks, and then till 19 weeks, I would continue, because that's the second placental wave I feel we should take care of. Anybody agrees to this practice? Because I know, again, there are no evidences, only 30 to 35% possibility of improvement. But then it helps us because L-arginine is finally a protein, which we are giving. Anybody would want to agree or disagree to what I am doing on the panel? Yes, Dr. Gayatri wants to say something. Yes, madam.
Yeah, no, I fully agree with you. And I always explain my patients with the difference, as well as few micronutrient support and sometimes IV support gives very good perinatal outcome, even 2 or 3 times at the interval of 1 month with naturally oral treatment control. So definitely, Girija, it's a good thing because long bone, even not only the measurement, but the shape also sometimes give us intuition that we have to follow these fetus, the little banding or a little density, less density of the bones. So I think I am also involved with the long bone scan and comparison of long bone with the BPD difference.
Yeah. So we have to be looking at
and
all
that is the my
Absolutely. Yeah, because I'm now trying to rush a little because we don't want to miss on time. We have the second panel to come up. So we have to be on guard with this patient, talk to the patients about various problems that they can have. And the moment we find that the blood pressure is abnormal, we have to give them close surveillance. Currently, maternal echo has also come up with a better assessment, and you can consider doing maternal echo even before embryo transfer in high-risk mothers or during 32, 34 weeks of pregnancy to understand how she's dealing with pregnancy adaptation, so that can help you to be better, because there have been problems of the the cardiac involvement in the mother with GDM as well as preeclampsia, severe anemia and obesity, and therefore this additional thing, I think as ART specialists we must consider looking at the maternal health in detail. Now, fetal surveillance, we've been following the entire gamut of fetal surveillance. We do all that, and we've learned, and Dr. Sonal has always been talking about this and teaching us many a times. But Sonal madam, I want you to throw a light on the CPR ratio. We want to understand it a little more because it helps us in identifying when to deliver our babies. The CPR ratio, that is the cerebroplacental ratio, how do we place it in the fetal surveillance for fetal growth restriction as well as preeclampsia? If you can guide us.
Of course, if we are talking about the Dopplers for the fetus, it ideally should be a serial assessment, and without that, you would not get the correct idea about what is happening with the fetal circulation. But CPR has been given a credit of one very important marker for to decide whether we need to terminate the pregnancy if the fetus otherwise has reached maturity. We all know that a CPR ratio of less than 1, CPR ratio is a ratio of the MCAPI to the umbilical artery PI. And if we all know that normally am I audible?
Yes, you are.
Yeah, we can hear you.
Yeah, okay.
Very well.
It is normally we all know that it is the MCAPI which is much higher than the umbilical artery PI. So normally MCAPI to umbilical artery PI, the ratio is always more than 1. But if it reaches 1, till then probably we can wait. We can do whatever immediate action that we want to. So, for example, if the fetus is not mature still, we do not have sufficient NICU, we can wait till then. But beyond that, if the CPR goes below 1, the chances of fetal morbidity and mortality goes to very, very high. And therefore, because I don't want to describe everything, it's going to be too long. So I'm telling you that if the fetal maturity permits us, if the CPR is less than 1, we should deliver the baby.
Absolutely. So therefore, we have to take a recourse of looking at all these things that we have, the tools that we have to help us in currently identifying. Now we will have quick answers because we don't have so much time about diabetes. How do you screen, Dr. Pallavi, if you can tell you, how do you screen your mothers for diabetes who have conceived with ART? Because we have a very high incidence of diabetes in India.
Yeah, I think firstly, on history, it would be clear that we need to keep a watch for her for possibility of developing a GDM, then her maternal age, weight, racial origin, strong family history. And I mean, any previous history of GDM in previous episodes of pregnancy or miscarriages or whatever during the course of her treatment. So that would become her clinical screening, and then we could have the entire blood work with her fasting and this thing when she's pregnant, with a basic HbA1c and a glucose tolerance test done. She needs to be put on with an endocrinologist, a competent one who would nearly steer up her sugar levels, help her in maintaining the HbA1c levels to maybe upper cutoff of 6.5. And then she needs to be switched on over from maybe on, earlier if she was on oral antidiabetics, she needs to be switched on insulin for her pregnancy. So that can be taken up care with the endocrinologist. So that happens, the blood work and managing her sugar levels. And then clinically, you have to for on ultrasound and her personal weight gain, and then all the soft markers of the pregnancy of the first trimesters and second trimesters not to be missed, including the dual markers on time. Yeah, then the NT scans, the quadruple test, everything falls in place.
Absolutely. So you rightfully told us, Pallavi, that, DIPSI is something that we have recommended universally for all pregnant women in our country, looking at a very high incidence of diabetes. But Pallavi has made a very important point that if you have an ART pregnancy who has a very high risk of diabetes, because of the virtue of the fact that you've probably given her quite other, there are a lot of other associated factors, you have to look at her for diabetes, as if diabetes is going to be there, and then maybe consider her taking to an endocrinologist and approach teamwork. So friends, very important message, that look for diabetes in our ART patients, and that is going to help us. And of course, we have to get through the structural assessment of the fetuses during this time period. Even if she has been a non-diabetic before becoming pregnant, during the second trimester, she has to be looked closely for the fetal surveillance. There can be a possibility of macrosomia, which we are worried about. And as I've been talking about, look for very close surveillance of mother. And Pallavi has also been saying that I would look at the mother more closely. I'll put her onto the endocrinologist and try to take care of her, because she may require a fundoscopy, ECG, cardiac evaluation, and so many other things, and surveillance for urinary tract infections and the bacterial vaginosis. And coming to VTE now. Now, I feel that most of the times we are using the LMWH very, very rampantly, and therefore VTE doesn't occur in our patients. But what about the perinatal component, Dr. Pallavi? Have you started, apart from the fact that she is an infertile patient, have you prophylactically started? Anybody of you can take this question.
No.
Have you looked at VTE possibility in these patients and considered that I must start antenatally LMWH for this? Anybody?
No, madam. Injectable, not in injectable form.
We give ECOS, I think low dose aspirin.
That's the only upper cutoff.
So we are looking at low dose aspirin, and we are looking at ambulation a little bit, but I will also share some of my IVF patients have brought in wheelchairs by their husband. Okay. Of course, they never conceived with me. They came to me for high risk care. But then we have to be aware of.
It's very unfortunate. Yeah, what can happen?
What can happen? And definitely post-delivery, we must look at these protocols of management and assessment, and we have to be aware of the possibility of venous thromboembolism. Now, among the fetal complications, we discussed about the fetal growth restriction, preterm labor to an extent, and structural abnormalities. We have not dealt with, but I think all of us will put them through the reverse triangle of antenatal care, and aneuploidy screening will be done very, very closely. Once at confirmation, then at 9 weeks, and again at 11 weeks, and maybe at 13 to 14 weeks, because we have to be really sure as to what's happening. But one of the concerns today, because we are in the pandemic, I want to share, because there's some of my friends who have had these experiences where patients have suddenly landed in IUD or stillbirths, and they are your precious IVF patients. Have you done any change in your protocols in this context? Anybody? Have you had any experience? Okay, by the time you're thinking, I'll share an experience with you. There was this patient who was conceived with frozen embryo transfer. And then at around 20 to 21 weeks, she said that she's not feeling very well. And then she said, I used to feel some little fluttering. She had just had a sonography done. Everything was fine at around 16 to 18 weeks, and 3 weeks had passed. And then she said, I'm not feeling well. Sometimes I feel feverish and all. I said, why don't you come up? This was in the second wave. And when she came up, we found that everything was fine. Fetal to deco was fine. There was a little raised pulsatility index in the uterine PI. And I said, what are you taking? And she was taking low dose aspirin. Just out of the blue, I felt, let's do your D-dimer levels.
Oh.
And we did a D-dimer levels. They were in the range of 4,000. Okay. And that was the trigger which I used to start her on LMWH. And I felt that we could maybe ward off IUD, which would have happened. So I think in the first wave, we were lucky because we are not doing any IVF practices. But in the second wave, I think most of you must have had these challenges. Anybody wants to share any experience in this context? Okay, doesn't look like one. Now, for congenital anomalies and birth defect assessment, I think we will have a special session with Madam Sonal. But Sonal, Madam, can you tell us as to when do you think would be the right time to do the cervical length assessment? Because the ACOG, the RCOG, the FIGO to an extent say that do it at a transvaginal sonography at 16 weeks of gestation. And there would be no harm in calling these patients for early anatomy scan at 16 weeks because these are precious pregnancies, and which I think all of us practice this. But they also mentioned that you do it at 18 to 19 weeks of gestation. That's what FIGO says. So what would be, and before 16 weeks, there's no point because there's no lower uterine segment to differentiate. So what's your take on this, Dr. Sonal?
Our practice is to do it between 16 and 18 weeks always.
Okay.
And if it's not just a static assessment of the cervical length,
okay,
usually we'll take a cervical length, measure the cervical length, and that's always done on a vaginal scan with an empty bladder. With no pressure. I mean, if you press, you may decrease, the cervix is soft and you may get an error in the measurement. If at all, it is a borderline measurement, like about 3 centimeters. That is when we will always give a fundal pressure and try to assess if any funneling occurs or there is any shortening of the length. And if at all there is a shortening of the length on the fundal pressure where we are doing a vaginal scan, in this cases, because the cervical length at that point of time is normal, we will repeat again in 2 weeks. If it shows any decrease, a decrease in the vaginal length of at least 10% in 3 weeks indicates you have to do a cerclage.
Okay. So I think that's a very important point.
Also use elastography, and that's also one very good modality. There are 2 types of elastography, and I'll not discuss that in detail, but elastography also tells you, even in presence of a normal length, the softness of the cervix. And if the cervix is soft, with the borderline measurement, of course, even in those cases, cerclage is indicated.
Okay, so cerclage indicated, non-indicated is one thing that we have to address. Dr. Vandana, do you do a universal cervical encerclage in all your ART patients?
Yes, I would like to do
universal cerclage. Okay, you are quite brave, I must say, because I would be scared to do that. Dr. Kajal wants to say something. Pallavi is saying no.
No, ma'am, not as a universal.
Okay.
Because any intervention, we should always keep in mind like the other side of the surgery also. Yeah.
You may stimulate a reaction, maybe fibronectin.
It is unnecessary point of irritation continuously. I mean, if it is, obviously in very indicated patients, you should, as per the evidence, but no, not for all the patients, not even twins.
Yeah, so Dr. Sonal Madam told us about how we would look at a surveillance and a dynamism of cervical length. And I think that's a practical approach to take. And then whenever you get the opportunity before 24 weeks of gestation, always look at the cervical length, and that would be your guiding point, whether you require to take the cervical encerclage or not do that. So that was one thing. Dr. Sonal, we also want to share with you this study wherein they found that in twin pregnancy, because that's another question which Kedar wanted me to ask the panelists, and I'm asking you this. For twin pregnancy, do you take a universal cervical encerclage?
No.
Yeah, Pallavi says a vehement no. Kajal, she's not sure because there is a high incidence. Yes or no, Kajal?
Yes, ma'am.
Universal?
For not all, ma'am.
Not all.
No, that's she
Yes,
asking.
if it is indicated, then only.
Okay, so again, both two of our panelists mentioned that they will do it only if it is indicated. And this is that study, Dr. Sonal, I wanted to say that they observed that twin pregnancies have a different kind of a cervical behavior and the dynamics during the entire gamut. There's, a pattern 1 which shows a stable cervix, pattern 2 early rapid shortening, pattern 3 late shortening, and pattern 4 early shortening with plateau. Have you had this experience, and what would be your tip on this context to us, especially in a twin conception? What should be our trigger to look at it as a shortened cervix?
Early rapid shortening is what will probably require cerclage.
Yeah.
If the cervix is stable, you can probably just wait and watch. With the late shortening, it is a little difficult because then it would be probably too late to do a cerclage.
Absolutely. So I think what is important is to drive a point, because Sonal madam also mentioned about elastography. And we all have to remember one thing, that is not the cervix which is completely short or anatomically short. It is actually a process where it is undergoing an inflammatory change and a breakup and shortening. And that consciousness is very, very important, because then that will help us in identifying which is the patient in whom I would take a cervical encerclage, and which is the one I will not fiddle with it, lest she lands up in a prom or some such kind of interventional related issues. So that brings a lot of things into perspective for us, and we agreed to the fact that we would be doing screening for cervical length in these patients because they are at risk and they are precious ones. And then we also discussed some less part to the fetal growth restriction. Now, quickly, in the last part of our entire thing is the placental abnormalities. And we know that there are various risk factors for ACRETA, and especially quite commonly so in ART patients, because the uterine decidua and the endometrium may have been accessed due to for some reason or the other. And there are certain points where we look at it. So, Dr. Sonal, again, what are these points where you would suspect that I must look at this placenta carefully? Because sometimes we see in the placental, some hyperechoic pools, some sinuses. And I have seen that these patients have had either a morbidly adherent placenta or sometimes even ACRETA. So what would be your tips for looking at these placenta?
The answer to that question of yours is every pregnancy placenta must be assessed as carefully as you do for the fetus. And even if you don't do a monthly follow-up, you should always evaluate it once during your nuchal, once during your second trimester anomaly scan, once at about 30 weeks. And if you find any heterogeneity, any lakes, any calcifications, any irregularity of the placental myometrial interface, in all these cases, close follow-up is required. Whenever you find there is a breach in the interface between the placenta and the myometrium, in all these cases, a close Doppler and preferably a 3D power Doppler study would be very helpful to find out how deep is the penetration of the blood vessels, and thus try find out what is the whether it's ACRETA, PERCRETA, and so on, and that will tell you whether how deep towards the bladder. So that is what is very, very important. So placenta, it's not like in which pregnancy, it is in each and every, and especially when it's an ART pregnancy, every pregnancy.
Absolutely. So any pregnancy is a message that madam has given you. First ultrasound, if the JSAC is in the lower uterine segment, in the scar beyond guard, any anechoic placental areas and an irregular placental myometrial interface, and a very thin, less than 5 mm angiomyometrial thickness, trigger up, escalate analysis of this patient for a better radiological analysis, and you may get your answers. Many times we very send the patient, do MRI, do that. Many times it may not be necessary. Just by doing a 3D power Doppler, you'd be able to identify. So in summary, we have to look from the time of the booking for minor risk factors to major risk factors to the emerging risk factors. background risk assessment, trying to deliver and identify risks as much as possible earlier in the timeline, trying to modify. And there were some wonderful messages that came by looking at the holistic approach of the patient's weight gain, diet, then mental health. Somebody spoke about diazepam. I think even counseling would be important to these patients because they unnecessarily get anxious, and these factors can help us better deal with these issues. Now, coming to the very, very last point, and this is going to be in the just next 2 to 3 minutes. How do you deal with lactation education in your patients, Dr. Vandana? Because we are finding that most of these ART patients have a lot of anxiety that they carry perinatally and then into the delivery. Now, delivering an ART, I think we can ask the ESA chapters to have a separate panel discussion on this. But we would want to shift to lactation because in the prenatal care itself, I think lactation education has to be a part. So, Dr. Vandana, are there any specific protocols or practices?
One must have very strong supporting system in our hospital and in relatives also. So that makes most important, that is the most important factor. So important is you encourage them for the breastfeeding, and the maternal health and maternal age does make difference. But most important is counseling and support.
Absolutely. Anybody has any?
Madam,
I have never seen a single patient who has breastfeeding failure unless and until it is very
Madam,
well
yeah. I think I would like to add something. Since ART, we know we are dealing with the age group, which is slightly higher than the natural biological age group of mothers. So these are most of the times, 80% of the times, they are all 35 plus. So this is the age is the one basic driving force. So counseling has to be very strong as to what we are looking on to, because independently the patient's mental frame would also put in an addition, right? So and then you have to counsel them and teach them about the available support system, like how to make best use of the breast pumps and hydration of the body, adequate hydration during the lactation. And I think it is really a very good idea, since this is once we have delivered the baby and handed over the baby to the mother, and then they'll be in the clinic or hospital for 2 to 3 days, but then they are spending rest of the time with the baby at home. So it is very modest to introduce them with a lactational consultant also, because it is a continuous process. And they would be, after getting delivered, they would be maybe visiting our hospitals once a month or on timely basis. So I think we can take up the idea of getting them introduced to lactational consultants also.
It is really difficult in patients with their babies in NICU or pregnancies, right?
Yeah, especially preterm babies, and especially some women are so anxious. They have not moved at all during pregnancy, and then they are the ones who are not able to do lactation satisfactorily because they don't get up only from their bed. They're so tired, and so therefore we have to talk to them about the advantages and the disadvantages. I have to tell my patients on the delivery table itself. अभी next ice bucket challenge. पहले breastfeeding शुरू करना है. मैं देखने आऊंगी तुमने breastfeeding शुरू किया कि नहीं. And then I tell them that 3 things like a road. It's going to make your baby stronger. Baby will not have diseases like diabetes, blood pressure, and you will not have cancer. So and we have to help them and come up with this.
So and position also we have to teach them for the breastfeeding.
Correct.
And continuous encouragement is very much required.
Kajal, I agree to you. कभी in frustration I tell my patients sometimes, अभी मुझे तो तुमको कैसे खाना करना है, खाना पकाना है, कैसे रहना है, कैसे प्यार करना है, ये सब सिखाना पड़ेगा. Let me start a nursery school for mothers where I'll teach them all.
Parenting also, ma'am. One of my patients came, ma'am, आप अभी parenting सिखा दो. I'm like,
बस हो गया.
Life is a continuous process.
Yeah. So I think I put my hands together thanking you all for being wonderful panelists. There's a lot more that we can discuss, but in the time that is allotted and with looking at the magnanimity of the program, I think we have been able to touch a lot of things. I want Dr. Sheila to comment on this, whether we have been able to reach to their expectations from the ESAR group. And I also take this opportunity to thank you all and to remember my name. I'm Dr. Girija Wagh, and I'm also contesting for Vice President Foxy from the West Zone. And I want not only all of you to vote, but all your friends, students, colleagues, everybody to kindly support me, because I want to win this election. And I'm your own candidate of Foxy. Thank you so much.
Thank you, Girija, and all the
have you
best.
as a moderator.
Thank
All
you.
the
Really a
best.
nice discussion, ma'am.
Malina, you enjoyed it? Thank you so much.
The panel is thanking you.
And
for-
we are sure to have you as a Vice President, West John.
Thank you.
Hi, Palvi.
All the best.
Enjoy.
We really enjoyed the entire panel discussion. I think it was a journey, and we had good time. First time, and many times what happens in these discussions, the time is short, and but the way the whole discussion and the moderation flowed, it was like a flow of a river, you see, where we would enjoy every aspect of so many angles which are there to this particular complicated area of pregnancies which are emerging out of ART, that they are continuously in the learning stage. I think we never stop learning, as they say. And each and every one of the panelists, of course, Girija, you were just fantastic to bring out so many issues in such a short period of time, because one can say even 1.5 hours
Very
is not sufficient. But still, all the panelists have done remarkably well, and they brought out their own experience. They shared it with us, and it was a great discussion. We have also learned a lot. I'm sure many things we see them repeating, but there are many things which offshoot, and there are rare issues which are discussed here based on their own experience. So we have learned a lot, and I'm sure the audience and those who have logged on to this particular panel discussion and this program, they must have gained a lot in this particular panel, which was dealing with pregnancy post ART. And I thank each and every panelist who is present. From first Dr. Girija Wagh, Dr. Pallavi Satarkar, Dr. Gayatri Thakur, Dr. Vandana Amin, Dr. Kajal Pangukia, and all others who have been so much instrumental in bringing out all the finest aspects, what you say, of pregnancy post ART, right from conception onwards and the first trimester. The whole knowledge has flown to second trimester as well as the third trimester. And right from conception, we have taken things up to placenta, accreta, and whatnot. And even breastfeeding has not been missed out. So we can see that it has been a great discussion, and we are very, very happy to have this panel today. I'm sure there was a lot to learn. Thank you all very much.
Thank you, sir.
Thank you so much. The panelists inspire me always. Thank you. Hi, Dr. Nagori.
Dr. Nagori sir is here, and we are so happy to have him.
Yeah.
Yes.
He is one of my heartthrobs, from Surat.
RJ sir, hello.
Hello, Pallavi. Hello.
Hi.
Hi.
Hello, Gayatri madam.
હવે 6 થી 9 નું શો ચાલુ કરો. બેઠા છે શાંતિથી.
Thank you, Dr. Girija.
Thank you.
Sonal, and all the best. Yeah.
Thank you so much.
Thank you.
Thank you,
So,
sir.
Dr. Nimish Firoz,
Nimish bhai, thank you and all the best, and congratulations for first webinar as a president Gujarat ESAR. You are welcome, and very good webinar, Nimish bhai.
Thank you so much. It has to be
And
good with all of you around. It has to be
All
good.
the best.
All the best.
Thank you.
Yeah,
Thank you.
all the
Thank you,
best.
sir.
Yeah,
Thank you.
Sonal Nagari sahib.
Thank you.
Thank you, Nimesh sir, for
Thank
giving
you.
this
Thank you.
opportunity to me.
No, it is a great pleasure, Kajal. I think we want all talents to come together, because then we get the best out of them. And we are also one of our committee members in the Gujarat ESAR chapter. So I'm sure you will also have much more to contribute later. And of course, everyone, I think Dr. Pallavi Satarkar also brought out many
Thank you,
things
sir.
practical.
Thank you.
Practical
Thank you, sir.
things. Yes.
Well done. All panel have well done. Very nice discussion. Very informative.
Thank you, sir.
Thank you, sir.
Komal, may I request you to start with slide presentation of Dr. Seema ma'am's introduction? Nimish,
So,
sir, may I-
Amit sir, before starting the introduction of the second panel, can we play the video of Central Relay, sir?
No. Dr. Seema ma'am's
Okay.
introduction, she will say something about the video. You first start with her introduction.
Hi, Girish.
Dr. Nimish, sir, maybe
Standard I have to follow. I don't know where I'm going to. Wonderful panel.
It definitely will be good.
Yeah.
No, don't worry, Dr. Seema. It
Yes.
will be great. Just great. Just don't worry. We are there with you.
Dr. Nimish, sir, can we request you to introduce Dr. Seema ma'am once?
Yes. It's my great pleasure to have Dr. Seema Pandey. And she's the president of Azamgarh Obstetrics and Gynecological Society. Azamgarh is a very important, no, not so big, but a very important city of Uttar Pradesh. And she is from Azamgarh. She's also the National Executive Committee member of ISAR. She has co-authored A to Z of PCOS. And she has co-edited Foxy Handbook of Drugs in Infertility, Foxy Focus Preterm Labor, Anemia Journal, and basically her key interests are infertility, reproductive endocrinology, PCOS, adolescent health, and pregnancy failure. And she has been spreading a lot of awareness about PCOS and adolescent health among schoolgirls through health checkup camps, and talks through her Surabhi, that is one of her vehicles to bring about an awareness socially about the adolescent health. And she's the director of Seema Hospital and Eva Fertility Clinic and IVF Center at Atraulia in Azamgarh, Uttar Pradesh. Seema, we would like to visit Azamgarh sometime and look at that part of the territory which we have not yet seen, and I'm sure the occasion will come. So very nice to have you again on this panel to moderate this particular very interesting panel discussion that is now flowing out on the gonadotrophins in ART, and of course IUI. We'll cover IUI as well, so that we start from the basics and then we go on to the higher applications. So Seema, it's a great pleasure to have you, and we may start with the panel, but I think there is a video to be shown. So if that is the part of the program, then let us go ahead with it.
Seema, please unmute yourself.
Thank you so much, sir, for such a kind introduction. Because of rains, I lost my connection for a moment. So on behalf of PPSAT 2021, I welcome you all to this panel, Gonadotrophins in ART, sir. And I welcome all my esteemed panelists, as Girija very rightly said, that they are teacher of teachers, and we are here to learn and extract as much as possible from them, as what are they doing in their practice, what tricks are they performing for becoming who they are. So let's start. Before that, I would request Amit to play that video on behalf of Team ISAR.
Yes, ma'am. Komal. Thank you. Ma'am, you'll have to unmute yourself.
Unmute.
Thank you so much. And I will request all the audience and panelists and all the participants to get benefited by these schemes running by Central ESAR, which are in patients' benefit. And please get accredited for, and the maximum number of ESAR membership is going, the state which gets is going to get awarded for that. With this, I would share my screen and I welcome again all my esteemed panelists. Just give me a sec because
Yes, we can see you very clearly.
no, I am not able to find the place for sharing. I'm not getting my, yes. It's not sharing my dashboard. Can you share my screen? Can you see my screen?
No,
I'm not here.
just
I've already started my screen.
You must have not shared it.
Yeah, I'm doing that only. I cannot see myself right now. So I'm sharing again.
Ma'am, you can minimize your presentation first of all. Come to this full screen.
So it is saying open system preference for my desktop. I don't know why is it saying. I did it yesterday only and I was able to.
After you press share screen button, it is saying this open system preference.
Yes.
Okay.
Just minimizing everything. I am having only this.
The slide is saved on your laptop?
Yeah, it is opened also in slide share mode. Share sound, it's written optimized for video clip, but I'm open system preferences. What does it mean? Can you just help me?
This is the this error we are getting for the first time actually, doctor.
Yes, even I am getting for the first time. I have never got it.
So just try to log in again. That's what we can do, I believe.
I'm also sending the presentation to you.
Please do that, ma'am. Yeah.
Dr. Seema, I think it would be the best thing if you can just log out from the Zoom and come back to Zoom. That would probably work.
Okay, I'm doing that, dear. I'll do it immediately. I was thinking that I send it first and then do it. So I'll do that.
Komal, in the meantime, you can just play a video.
Sure.
Yeah. So, dear doctors, basically MCure IVA as a division, we have conducted 228 webinars till date. Programming 28 is a scientific for the theme for the year, and it encompasses, or it is based on the. Yeah, please play.
Anyway. So I believe Dr. Seema has joined me, right? Again, I can see her in the participant list. Dr. Seema, can you please unmute yourself and start the video?
In the meantime, Nimi sir, you can help us understand how your Gujarat ISAR chairmanship have started or begun with you. So how you are feeling?
Yes, it's ISAR. I will talk about ISAR itself. There's a Gujarat chapter because the chapter first came into being in the year 2010 when we had a meeting at one of the All Gujarat Gynec conferences at Bhavnagar, and it was decided to inaugurate the chapter, which was done at a subsequent meeting, and there are about 15 founder members at that time, and we started the Gujarat chapter of ISAR in 2011. And in this, the first president was Dr. Naina Patel from Anand, and the secretary was Dr. Kanti Bansal, who has been one of the immediate past presidents of Gujarat chapter of ISAR. So then the chapter grew in terms of its growth, in terms of its members from 2011, and it started disseminating a lot of scientific programs which were held at various places in Gujarat. In fact, we didn't even miss out on taking an excursion to Mount Abu, which is in Rajasthan, close to Gujarat border, and we did one program there also. But various CMEs and programs have been held thereafter in all the major cities of Gujarat state and even smaller places. And Gujarat ISAR is a very vibrant organization as a chapter of the Central ISAR. Thereafter, it was in 2014 that we had the next president coming in. It was Dr. Chaitanya Nagori sir, in fact, who has been one of my teachers in the past, and it was a great time we had under his tenure. And in fact, in 2014, Gujarat ISAR chapter did the National ISAR conference in Ahmedabad. And we had a very huge gathering in Ahmedabad at that time with a lot of international speakers, and it was held at the Gujarat University campus area, where we had a very big auditorium, and it was a great program. Thereafter, in 2016, there was the next president who came in, and that was Dr. Kanti Bansal, and she went into a lot of details, did a lot of academic work in those times with a lot of publications and books which have come from Gujarat chapter of ISAR, from various talented scientific specialists, right from imaging to those who deal with andrology, those who deal with gynecological part of infertility, male infertility, and various aspects of human reproduction, which are a challenge in fertility treatment. So we have had, as you say, the chronology of how Gujarat ISAR chapter came in is very, very typical, and how it grew into leaps and bounds. In 2018, we had Dr. Tushar Shah as the president, and currently he is the immediate past president. And a lot of activities happened during his tenure also. Only thing was the COVID time, which started from February 2020, that we had these virtual meetings. So from then on, things have been virtual, and I have just taken over last month from Dr. Tushar Bhai, and we are looking forward to having also virtual meetings, even possibly hybrid meetings, which are much likely in the coming times, and then of course live meetings, which are not virtual but real meetings. So let us hope for the best, and do the best for Gujarat chapter of ISAR and Central ISAR. Yes, Kedar.
Hi. Good evening, everyone.
Yes. Nice to see you.
Hi, Nitesh. Bhai. All
Yes,
Matama.
So, Kedar.
I heard the full panel discussion, and it was wonderful. I have 2 or 3 requests from Central ISAR to you. One is the membership drive. We need members now, so it's in your hand. 8,000 rupees for Central as well as State Chapter ISAR membership. Second, accreditation of your IVF centers. That is something which is unique. It will prepare you for ICMR guidelines. And third is there are these annual conferences which have been conducted by, I think, when Manish Banker was the president or the chief organizing secretary of the conference. Now, what I'm trying to archive all the memories of old presidents, which were the past presidents of ISAR. But especially in Gujarat, there were 2 conferences which happened, one at the time of Firoza Parekh and one at the time of Dr. Mahendra Parekh. And for both the conferences, I have not got a single photograph or single brochure of the conference from anyone. So I'm going to send a message to all of you all in this committee, and I'm going to request you to send it to all the groups in Gujarat. And anybody can get me a single photograph also for these conferences. I will be highly obliged, because in the annual conference, there is going to be a board which is going to be put up for archives of ISAR. Okay? The old memories of ISAR are going to be put up as something new which we thought, but we do not have any archives from Gujarat chapter. Same is the story from Rajasthan chapter. I have not got anything from Rajasthan chapter also. So I want you all to, put in little efforts, take little interest, go to your archives. That time it must be photographed and not the digital ones. So you will be able to get it through. Amit, what is happening to Dr. This one?
Sir, her internet connection is not working that well, so she's sending the PPT to me. Give me a minute, that I'm yet to receive the mail. Just a minute. As soon as we get the mail, we will inform and we can start the discussion.
Kedar, I will try to look at the old photographs collections of those 2 conferences, and if I find anything which is relevant, I'll send it to you.
Absolutely. Now, according to me, there must be people in the committee,
Yes,
secretary, joint secretary, treasurer, all those things needs to be archived.
No, absolutely. I agree with you.
People have
photographs have been sent to the present secretary. I think Tushar and must be having all the photographs. So I'll see that it is sent to you within short time.
Okay, thank you very much.
I-
Amit,
Yes, sir.
now onwards, make it compulsory for all the speakers to submit their presentation beforehand.
Yes, sir. Yes, sir.
Okay.
That would be helpful.
Now this cannot, precious time for people, and people will leave. The participant will leave for such an important panel discussion.
Yes, sir. Yes, sir. We'll do that. We'll do that.
But tell her that without any evidence, you take the panel discussion. No practical panel.
I'll do that.
Why do you want a presentation?
I'll do that. I'll do that.
We can discuss without presentation. Even.
That's
Yes,
what
yes.
it is.
Let us do that. Let us do that.
You all are so stalwarts.
That way you can ask the questions.
Yeah.
Yes, better.
Hi, Girija. Girija, madam.
Just join the
Seema ma'am is live. She's sharing the slides. She has been done. It has been.
Hi, Arji.
Tell her, also tell Amit, tell her to keep her video off.
Yes, sir.
Only audio on so that it will
Yes, sir.
work very
Yes,
well.
sir.
Okay.
It will, sir. Sir, also, Kedar sir, I would like you to tell everyone about this Sadhana Endowment Fund, because there are many doctors who are speaking that this they are not completely aware or not full. So if you can detail a little in between.
Sir, in every ISAR Express, it is been put up. We have sent so many messages for Sadhana Desai Endowment Fund. It is rupees 50,000 rupees for one treatment cycle of IVF with self eggs. The center has to be at least ICMR accredited or registered with ICMR. Okay. The patient has to use her own eggs. No donor eggs allowed. Okay.
Absolutely.
And you have to submit their PAN card, bank details, Aadhaar card, and then the scrutiny will decide. Once you start the treatment, half the payment will be done to your center and the half money will come later on. Till now, 20 people have completed. Okay. So now Dr. Seema is here. Please start the session, please. We are already late.
Yeah.
If you require a little more time, Dr. Seema, please, I request Dr. Nimesh Elad to give a little more time to finish the panel, okay?
Sure.
Started? Amit, what is happening?
Sir, ma'am has said that she is able to share the screen. She has logged in, but apparently there is still some problem.
Yeah, again she has dropped off.
Amit, what I'm telling you, will you take the control?
I have actually informed her, sir. I have actually.
Take the control in your hand and start. Do you have a presentation or no?
No, sir, I don't have the presentation.
So tell Dr. Seema to come on the line. I will tell her.
I think straightway she can ask the questions.
That's it. Without any PPT, just start the discussion. Bas.
Okay, I will start the rolling ball rolling. Okay, tell me the indications of using gonadotropins in IUI cycles. Use of gonadotropin in IUI cycles. Dr. Patel, sir, boliye.
Yeah. We know IUI, whenever indicated, it is very cost effective. What is our aim? To have a good pregnancy rate, and worldwide it is around 20 to 25%. Initially, before starting treatment, we have to just investigate minimum sonography, any hormone test, and semen analysis, and our try to have a maximum result with the oral medicine.
Yes.
When oral medicine fail,
Can you hear me and see me?
we are not getting. Sorry.
Hello.
Yeah, she started.
Yeah. Sorry.
Can you hear me?
Yes.
Yes, we
ma'am.
can hear
Yes.
you.
Yes,
We
ma'am.
can hear you. Yes, please go on.
I'm really sorry, and this is because of whether it's rain.
Don't worry, just go ahead.
Dr. Seema, can I request you to switch off your video? If you switch off your video, audio will work. Otherwise, this internet is going to give you problem. Switch off your video.
Okay.
Nice to have Sejal, Dr. Sejal Nayak here.
Hello, sir.
Welcome to the panel. And of course, Dr. R.G. Patel, Ratilal is also there. And
Yes.
of course, all of us are, waiting for Seema to just start with the panel. And
So we
Good
continue.
evening. Yeah.
Communication.
And hello.
Yes,
Can
Seema.
you- yeah. Can you hear me? Sorry. Hello.
Yes.
Yes.
We can hear you.
Hello.
Yes,
Yes.
ma'am, we can hear
Should
you.
I?
Yes, please.
So should I start now?
Yes, please go ahead.
So my apologies for this. The fact that Strepto and Edwards, they achieved first live birth through IVF in 1978, and that was one after 101 failure. But the story of gonadotropins goes long way back. The first gonadotropin SCG was first of all commercially available in 1931 by Organon, and HMG was for in 1981, John and John, they achieved first birth through IVF using HMG, using a criteria devised by Lennonfield, and he got live birth after 3 attempts. Since then, we have come long, and now gonadotropin become a very instrumental part of our day-to-day practice. We are using to tackle.
Ma'am, we are not able to hear you. Ma'am, we are not able to hear you.
Can you hear me now?
Yes.
Yes, ma'am. Yes, ma'am.
Yes.
Very interrupted. Not here.
This is Amigo. This is Amigo done long time back. Give me a sec. Now, is it clear?
Okay, continue.
Is it clear? Yeah.
Yeah.
This has taken more than 900 IUI pregnancies, and they have compared gonadotropin IUI, CC IUI, and letrozole. And as you can see, and it was done by none other than Diamond and Richard Legros, two stalwarts of the field, and they found that gonadotropin IUI gives the best result in terms of 35.5% with a live birth rate of 32%. In spite of this fact, gonadotropin could not gain the momentum for becoming first drug of choice for IUI when it comes to unexplained infertility as per various guidelines. But if we look at the very latest meta-analysis 2020, they have also said that gonadotropin IUI are the best way of doing IUI, though the only drawback is multiple pregnancy, which can be decreased if we acquire strict cancellation criteria, if we just keep a look on our doses and we counsel our patient properly. So that brings my first question. What is your indication for gonadotropin IUI in your practice? So I'll start from Dr. Nimish. He is on top of my view gallery. So please, what are the various indications where gonadotropin IUI comes to your mind? And I'm taking into consideration that all the previous work like one patent tube and work with male and female is already being done.
Right. Seema, thanks for the question. The thing is, you see, basically, we want to have the objective of IUI is not too many follicles, because we want to see that the patient achieves a pregnancy with least number of follicles. So basically, we would start with clomiphene citrate in any case. But if you find and if you assess the patient with a past history that he has been given clomiphene citrate without enough response, then I think the issue of giving gonadotrophins and using the gonadotrophins in IUI would immediately come to our minds. Basically, these cycles are initiated with clomiphene citrate, and then from 7th or 8th day, we can augment them giving the HMG as IUI and develop a larger cohort of eggs. But it should not be so large, because overstimulation is not the protocol for IUI itself. So we should be very careful in using gonadotrophins in IUI with a lot of discretion, and be very, very careful because it is a cycle which is also a budget cycle for the patient. The cost of IUI cannot go very high. If we overuse gonadotrophins, then the cost will also escalate. So
Excellent
basically,
point, sir.
Yeah.
Yes.
Can
Yes,
so
sir.
mainly okay.
Yeah, please. If there is any other input, please go ahead, Ratilal. Please.
IUI mainly in hypogonadotropin hypogonadism. So this is the indication for the any gonadotropin in IUI. Second is the whenever you are stimulating with the oral ovulogens, if there is no success within 3 cycles, we can think about gonadotropin. Third is the whenever you are using oral medicine and there is a disturbances in endometrium. Endometrium is not good, remain thin in spite of good size of follicle, then you can think to switch over to gonadotropin.
Excellent point, sir. Anyone else want to add?
Can I add something?
Yes, sir.
Yes, sir.
I would like to tell you one thing, that IUI means gonadotrophin. There is no question of oral ovulogens because the pregnancy rates are very high with gonadotrophin and IUI. Second very important thing, if you ask any IVF consultant, how many IUIs you would like to go, somebody will say 3, 4, 2, 1 or 6. So if you want to try IUI, do it in the best possible way which gives you the highest pregnancy rate. Why would you like to go for 3 cycles of clomiphene if the patient does not conceive? Then you will try gonadotrophin. See, you are helping your neighbors. Many patients will go away from you because they have always the fixed time for you for getting a pregnancy. If the patient does not achieve pregnancy in 3-4 months, it is not going to continue with you. It is going to somebody else. So whenever a patient comes to me, I always adopt a gonadotropin with an IUI with at least 3 cycles, and the pregnancy rate will be very good. So before subjecting, otherwise these all IUI failures will be considered by an IVF consultant as 6 cycles have been failed. Actually, if you consider that which gives you the highest pregnancy rate, this cycle should be considered as a failure before taking the patient for IVF.
Very true, sir. And that's why we want all the inputs possible from all of you. Anyone wants to add something? So the basic aim of us, as Dr. Nagori has said, that to get the pregnancy as earliest as possible. So our neighbors, they don't get opportunity. And as Dr. Shailath has stated, that we have to be very careful regarding the cost and convenience of the patient, and we don't land up in complications. Sejal, and I think we have covered this quite beautifully. So the favorite topic which I wanted to discuss, I would like to take each one of you this question regarding what is your maximum dose for IUI, gonadotropin IUI cycle?
Maximum dose of gonadotropin for IUI cycles.
Yes.
Apart from hypogonadism, I would not go solely for gonadotropins. I would add on with the oral ovulogens. So to reduce the cost, especially in IUI cycles.
So that be my next question. Yes. Do you mix your protocol? You use oral ovulogen along with gonadotropins to cut the cost of the cycle. Yes, sir.
And then I will usually I go through the previous history of her previous cycles, if she responded at what dose or so. If she is the very first case or like first cycle IUI or stimulation cycle, then I would start with the like 75 milligram IU dose daily, and then monitor accordingly.
Yes, sir. Anything
And
else?
if she had responded previously with the 150 dose, and I would definitely check for her hyperstimulation status or maybe not responder, then I in next cycle or according to the previous cycle, I decide the dose. So best thing is to go with the previous
Dr.
history and the
Nagori,
papers.
excellent, Sejal. Dr. Nagori, what is your maximum dose for an IUI cycle?
We normally prefer to use letrozole plus FSH combination either for PCO or for the poor responder.
Yes,
The
sir.
whole idea of using a letrozole instead of trimifene citrate is the mechanism of action, that the letrozole we give from day 3 to day 7, and by the time the follicle develops, the estrogen goes back to the hypothalamus, will decrease an LH, while the clomiphene plus gonadotropin, the LH level will be high and estrogen is not perceived at an hypothalamus. So in spite of an high estrogen, more and more FSH and more LH will be there. So it can cause multiple pregnancy also, as well as it can have a high LH, which is detrimental to an ova. So the letrozole plus gonadotropin is a good combination because it gives more or less a monofollicular development, 1 or 2 follicles only, as well as it decreases the LH level. And that is why the pregnancy rates are found to be higher. And the cost you can reduce of gonadotropin by adding the letrozole with gonadotropin to the patient.
But my question is for pure gonadotropin cycle, sir. What is your maximum dose? Have you ever used?
There is nothing like maximum dose. You do a baseline scan, and
Yeah.
baseline scan will tell you whether it is a poor responding ovary, normal responding ovary.
Got it, sir. Got it. I mean to say, what was your maximum dose ever you have used or minimum with IUI and you got
See,
results?
I tell you, means from the beginning, you want the beginning, a total amount.
Maximum. No, single dose per day.
Single dose per
Maximum
day.
international units per day.
In an IUI cycle, maximum 150, more than 150 is not required. But majority of the patient requires only 75 units. And if the patient is severe PCO, then we go with 37.5 units. And then
So,
Dr. Patel.
Yeah.
For 14 days.
As well, the dose depend on the total age of the patient, AMH of the patient, AFC of the patient, cycle length.
Baseline scan. I tell you that you have to consider all 6 parameters.
Yeah.
That age, BMI of the patient,
Young hyperresponder, low dose.
of the follicle, all should be considered, and then the dose has to be decided.
So all
published a paper on
yes, you rightly say 150
That
in IUI.
Sono scoring system of yours, that is an excellent tool
150.
for IY people. Just because this panel was going to be focused on ART, I had to cut it short. So that Sono scoring system, would you like to tell something more about that, sir?
See, if you do a scoring system, then scoring system will decide whether you should, for what should be a dose for an IUI, what should be the dose for an IVF, and what should be the dose if you want to freeze the program. First, you consider the age. Second, you consider the BMI. Third, you consider the AFC of the patient. Then you RI and PSV, both should be considered, and volume should be considered. So then you give the markings, and according to the markings, suppose it is PCO patient, then the marking will be very high, between 20 to 25. So these are the cases where you start with 37.5. These are the PCO patient. While if the score is very low, then these are the poor responding ovary, and we start with 150 units for an IUI to this group of the patients.
Yes, Dr. Shailit, you wanted to add something.
Yeah, I think one thing that is very important is, we are able to now tailor these doses with multi-dose vials which are available. Previously, when we started, we went into ART in the early 90s, and even I would say till the end of the 90s, these types of vials were not available, and it was very difficult to tailor the dose with, say, fixed dose vials. But now that these vials are available, even as Dr. Nagori has pointed out, 37.5 international units of FSH stimulation in the initial stage for PCO cases is the most ideal one, because we don't want hyperstimulation, we don't want too many follicles also, and therefore we can streamline the cycle with adequate number of cohort for getting a good success in IUI. And when we are progressing and on ultrasonography and folliculometry, if we find that having given this, the dose needs to be stepped up, then we can still do it. From 37.5, we can make it 75, or from 75, we can go to 125 or even 150. So when we are talking of only gonadotrophies in IUI and we are forgetting the oral ovulogens, then this should be, if this is the way it is followed, we can really get the best out of the whole cycle. And in fact, now with GnRH antagonists, even GnRH antagonists can be used.
We'll come to that later, sir. We'll come to that later.
Okay, fine.
And first, thank you so much. And second thing, sir, is there any preference? Are you going for FSH? If yes, then purified or recombinant, or you guys are doing your IUI cycles with HMGs?
It's for PCOs and patients who have higher LH levels, basically FSH is always preferred. But when we have otherwise a case of unexplained infertility, when you don't have the gonadism problems, then I think FSH with LH is not a bad choice, because LH is also important for chromosomal maturity, and sometimes if you give only FSH, you do not get adequate chromosomal maturity at the end of the size of a good follicular size as well. So LH insufficiency should also not happen in such cases. So this is what our experience tells us.
Sir, Dr. Nagori, what is your view, sir?
If in an IUI cycle, we don't downregulate, and that is why the endogenous LH is always present. And when endogenous LH is present, there is no point in giving HMG to the patient. You always should give an FSH. The reason is that if your dose increases of an HMG, then you may cross a ceiling level. And once, because the FSH or the LH has got the threshold level, it has got a ceiling level also. So if you cross the ceiling level, it will spoil the quality of an OVA. And that is why you always should give an FSH to this group of the patient. The only indication of HMG will be when the age of the patient is more than 35 years, where perhaps the bioactivity is low in the patient as far as the LH is concerned. And these are the cases when your previous cycle has not given a good follicle. It means the LH bioactivity is low. And these are the cases where you can add HMG to the patient. So in an IVF cycle, people use antagonist and then they use either HMG or the Luveris is added. The same thing can be applied in IUI cycles, that if you don't get a good follicle by your previous cycle, then always add HMG if the age of the patient is more than 35 years or a patient is a poor responder, then you would like to add HMG because the bioactivity of the LH is low, and that's why the LH is required to this. But otherwise, no HMG, because we have not down-regulated. Endogenous LH is normal, and that's why only FSH is to be used.
Dr. Patel, what is your choice? One liner, please.
HMG. Very rightly say, FSH is prime gonadotrophin, but old age, hyporesponder, slow responder, and young but having low ovarian reserve, they need HMG.
Okay. Sejal, what is your view?
For IUI cycle, I would restrain using recombinant FSH. So highly purified or HMG. And as the sir said, about 35 years and poor responder would preferably use HMG.
Excellent, sir. But the thing is, if we go on evidence and we move towards ART, this recent Metaset and Merit trial, they are trying to use HMG in PCOS patient as well, along with other people like poor responders, the Poseidon group 1, 2, 3, 4, all the places. Recombinant FSH is being replaced by HMG, and as per Cochrane reviews and the recent 2019 ovulation stimulation guide guideline, irrespective of the type of isoform, whatever you are using, the results are same. And if we talk about ART, in fact, results are better with HMG slightly, though it did not reach significance because of the smaller sample size, but it was giving better oocyte quality, better embryos, better live birth rate, and better pregnancy in FET cycle. So the whole spectrum, the whole thing is just moving towards HMG more. And if we are talking about the cost constraint, then also recombinant FSH, where the rate of IUI pregnancies per cycle are not too much, and if you want to cut the cost, I think HMG makes more sense. But yeah, as you people are experts, you have been doing and getting the results, so this is a new thing we have come to learn. So if we, yes sir.
Yeah, normally what we are doing in a ovulation induction, like we limit up to 3, 4 or 5 or 6 IUI.
Yes.
So first cycle should be, if it is young and having less active married life, we can give the choice with the oral medicine to ovulation induction. Second cycle should be oral with gonadotropin. Third cycle should be with the only gonadotropin. Fourth will be gonadotropin with antagonist, and we'll limit the IUI.
That makes sense. So Sejal, your purpose of adding oral ovulation to this gonadotropin is just to cut the cost of the cycle, isn't it?
Yes, cost of the cycle, and you can like reduce the intramuscular injections also, or that is also, and more I can use the extended letrozole protocols for PCOS to like overall reducing the cost.
So even literature has the same sentiment. Gonadotropin either alone or with CC or letrozole, it gives very good pregnancy rate, though multiple pregnancy rates are towards higher side, and if you don't use it cautiously or it's not in expert hand, obviously dreaded complication known as OHSS is bound to happen.
Madam, there is a very good paper by Professor Roy Homburg, and this paper was read in 2006 Madrid conference, and then it came into the human reproduction also.
Yes,
that
sir.
if you use gonadotropin, and on one side if you use an oral ovulogence, the pregnancy rate is almost double. That is a landmark paper that in a PCO patients, you should go only with the gonadotropin rather than oral.
He is a firm believer of only gonadotropin IUI cycles, low dose for polycystic ovarian syndrome. So as we were discussing, one of the indication for pure gonadotropin IUI cycles, since all of you are ART experts and doing a lot of cycles, what is your advice usually to these hypo patients? Do you just counsel them to go for one IUI cycles, or they should be going directly for IVF?
No, we have handled many cases of hypogonadotropic hypogonadism. The patient have low estrogen, patient are not getting period, so uterus is very small, and we will start the HMG, FHH and LH both with the 75 and monitor how they respond. When the follicle become mature, we can just do one IUI. If it is pregnant, then well and good. Will not go for more and more IUI. Yes, in second cycle, we will counsel the patient and we will go for the IVF.
Nagodi sir, how do you do your hypo?
Almost about 6 to 7 patients in my whole career. I've got the patients of hypogonadotropic hypogonadism all have conceived with an IUI.
IUI.
To emphasize that don't underestimate IUI, because ultimately the fault lies with the follicle. If you correct the follicular development, then the semen count is normal, the tubes are normal, the nature will take care of the pregnancy. So what is important is, the only thing to be remembered, that two things are to be remembered, because when you have to increase the dose of HMG, at that time the multiple follicles may develop in these cases. And what is an ideal treatment? When after 10 to 12 millimeter of the follicle, when the number of follicles are more, you should decrease the dose of FSH and increase the dose of LH. If you decrease, that will restrict the development of the other follicles, and you will get only 2-3 follicles, and then you can do an IUI to this patient. And second very important thing is that you cannot use agonist as a trigger in this group of the patient.
No, you cannot.
That is a very important take-home message.
HCG to this patient, and that is why whenever you get multiple follicles, so that's why you should increase the dose gradually. All of a sudden, don't increase the dose. And if you want to increase, then after 10 to 12 millimeter size, the FSH should not be given. Otherwise, you will end up in a multiple follicle. You can restrict the number of follicles, and then you can do an IUI to this patient. If your IUI fails, then automatically you have to go for an IVF too. But IUI gives excellent results to this.
Yes, because if semen is okay, IUI
they can only pills for a long time. When they come to us, by the time they've always taken estrogen, progesterone, and majority have always a good uterus.
Okay.
Yes, ma'am. Can I add something here?
Yes, definitely.
Sir, as sir said that usually they tend to have hyperstimulation. So at the beginning of the cycle, we need to explain them. We may need the conversion from IUI to IVF if there is a hyperstimulation. So that one point should be considered in counseling.
Most of the time in counseling, you have to explain the patient that you need a long period of stimulation. And that's the reason why many ART consultants, they believe in directly switching up to IVF than IUI. But as people who are doing endocrinology and infertility at large, and they really understand the endocrinology, they may very frankly go for an IUI cycle, keeping all the physiological and endocrinological changes. I welcome Dr. Pawan Dheer also. So we'll move on to the next question. So Dr. Nimish, what are like difficulties you come across in a gonadotropin IUI cycle?
Basically, once you start with these cycles, you have to monitor them more accurately, because in an oral ovulogen cycle, you just prescribe to the patient and they take it orally. They need not visit the clinic regularly. But once you are only taking up gonadotropins and not resorting to oral ovulogens, then the cycle has to be monitored from the very beginning. And for this, from 5th day onwards, at least once you have started the injectable gonadotropins, these are the ones which have to be monitored through ultrasound scan. And as Dr. Nagori has already pointed out, we can start with a basic dose right from the beginning, and I believe in step-up protocol.
We are talking about. What are those difficulties? I'll include Dr. Pawan. We are talking about gonadotropin IUI, and I just wanted to know your view on the difficulties when you are performing a gonadotropin IUI cycle, pure gonadotropin IUI cycle.
We have not experienced any difficulties with these, if you ask me, because we get good response with gonadotropin. So for our protocols that we have set in our clinic, we do get good response, and the ovulation itself is also at the right time, and we have had no difficulties. I don't think in my experience there have been any difficulties using gonadotropins. Of course, if you land up with a poor responder, then that is a difficulty, because a poor responder is not going to respond even with the best of gonadotropins. There might be other factors why the patient is not responding.
Dr.
So
Patel,
per se, if you use gonadotropins, there are no difficulties with IUI.
So
Yeah,
Dr.
definitely.
Have you ever experienced any difficulty in your gonadotropin IUI
Over
cycle?
time, unexpected multiple follicle can happen. That we have to keep in mind. Close monitoring is required. Sometimes may need to do E2 level and LH level to avoid any premature LH surge. Our aim is to produce 3 or 4 follicles, not more than that. So if you have many follicles, you may land in the ovarian hyperstimulation. That you have to keep in mind, and you may end with the multiple pregnancy. So to avoid this type of problem with the gonadotropin, the problem is multiple follicle, OHSS, and premature LH surge. So if there is a multiple follicles start to develop, there is always E2 level is high, and that E2 level will surge the LH surge. So there is a premature LH surge leads to luteinization of the follicle, and the quality of follicle will become problematic, and the pregnancy rate will be decreased. If you continue continuous stimulation, then chances of OHSS and multiple pregnancy there and
So
abortion
we're
rate.
taking these questions very quickly. That's why I'm interrupting. So because of all these factors, as you have described very beautifully, premature LH surge, utilization, multiple follicles, OHSS, these patients, they have to visit you frequently, and that creates more cost along with that. And that is a reason for affordability. These are the reasons. Now, my next question is, like Dr. Nagori has already said that he doesn't believe in doing antagonist IUI cycle. Dr. Nimish was talking about antagonist IUI. Yes, sir. You wanted to add.
I told that agonist should not be used in an IUI cycle.
I'm extremely
Yes,
sorry.
exactly.
Yes, sir, that is absolutely true.
Yeah,
Yes, sir. So, how do you tackle your premature LH surge, and what % of your IUI cycles are antagonist cycles? I would like to know individual responses from all my esteemed panelists.
Now, premature LH surge is always a problem because you have to monitor the cycles with daily serum levels after 8th or 9th day when you are suspecting these kind of patients. So till the antagonists were discovered, this was always a problem. And we had these premature LH surges which led to failure of treatment many, many times. With antagonists, normally what we do in our setting is that from day 9th or 10th onwards, when the cycle and the follicular size crosses 12 to 14 millimeters, it is at that time that we initiate a GnRH antagonist, and we give them subcutaneously as usual, so that the LH surge is controlled. Because what happens with antagonists, there is an immediate blockade which occurs, unlike the agonist. In the agonist, with there is a lot of effusion of FSH and LH in the initial stage because pituitary is stimulated to let out these gonadotropins. But in antagonists, this happens immediately, and there is a block immediately. So there is no surge coming up from the pituitary. Therefore, the entire cycle is under control of our own manipulation and the dosages that we administer. And therefore, it is the best way to control premature LH surge for the next 3 to 4 days when the follicular size under the GnRH antagonist and of course gonadotropin stimulation goes to 16 or 18 millimeters. And then depending on the clinical parameters, we can induce ovulation. Yes, Dr. Nagori, you are saying something.
Yeah.
I would like to tell you that there is a definite role of antagonists, but don't be guided by the representatives that the antagonists help to increase the pregnancy rate. It is not to be given to all the patients. There are very peculiar patients where you would like to give antagonists, and one is a thin, lean PCO patient. In a thin, lean PCO patient, the LH level is high, and these are the cases where you would like to use an antagonist. But there is always a difficulty that in which patient you should start and in which patient you should not start an antagonist. So I always tell you that in a previous cycle, if you have observed by an ultrasound that increased echogenicity of the wall, increased peripheral RI and fluffy endometrium, these three indicates, and uterine artery PI will also increase. These are the definite criteria that the LH surge has occurred. And in the next cycle, you should always start with an antagonist. So whenever you, in any PCO patient, you are giving a gonadotropin and observing a cycle, then during that time, you must observe the echogenicity, increased polyfollicular RI, if it is there, fluffy margin. This is a classical finding of increased LH surge, that a fluffy margin before the follicle ruptures, the fluffy margin you get, then you are getting an LH surge. So in the next cycle, you always should start an antagonist.
Rightly.
These are two topics which we really have to note down so that we can follow it in our practice too.
Rightly say, in a young PCOD or multiple follicle, chances of LH surge is there. One second is when there is a follicle is ready, but endometrium is little on lower side, triple line, but on lower side. So continuous stimulation with the antagonist, the follicle continue produce the estrogen level without LH surge, and the follicle when become more mature, endometrium is mature, then you can trigger it. Second. Third is sometimes people are using to avoid the weekend IUI. That is an antagonist, and you can use in a weekend.
Very existence of antagonist
Fourth indication
was based on this earlier.
And
So
fourth is old age, having decreased ovarian reserve, there are tendency to produce premature LH surge. So in old age, again, you need antagonist to add in the last 1 or 2 days. Continuous stimulation, just control the premature LH surge with antagonist, continuous stimulation, and then trigger it. So there is a specific indication.
Yeah, yes, ma'am. I wanted to add the same when I want to schedule the IUI. So I add the antagonist like a day later or so. And whenever we have to convert it to IVF, then we add antagonist.
But one thing is there, don't give unnecessary.
So
it doesn't give that good
next
result.
question. For how many days you people are giving antagonists? There are people who are giving single dose. There are people who are giving half dose every day, starting from the particular follicle size till day of trigger. What is it in your practice? And let's do it quickly so that we don't
the size of the follicle
left with questions.
When the size of the follicle is between 13 to 14 millimeter, you should give till the day of HCG. You should give always on the day of HCG also. The antagonist is always given in the morning. The trigger is always given in the evening, so that after 36 hours you can do an IUI. So from 13 to 14 millimeter size, you should start antagonist. So it normally requires 3 or 4 maximum, not more than that.
So in my practice, I do it whenever there is previous response, as Dr. Nagori has said. And sometimes I use very much in short follicular phases, where especially in poor ovarian reserve, where these premature luteinization and things occur at 15 or 14. And as Dr. Patel has rightly mentioned, that there is a dyssynchrony between endometrium and follicle because of that. On day 10, follicle is 20 mm and your endometrium is still 5 or 6 mm. I think we have lost Dr. Pawan. His room is visible, but he is not. So I'm not able to ask him any question. So coming to this, I was surprised to know that 25 to 30% of our cycles, they undergo premature luteinization, and that could be one reason of our IUI failure. And being an ART specialist, we always look upon that IUI doesn't give good result. That could be one reason. And there was a very good article by Dr. Ghulam Bahadur on reappraisal of IUI, and where he has mentioned that if we start using these good antagonists at right time and right manner in properly selected patients, the result of our IUI cycle would increase so much that 25% of our subfertile population will not be needed to move further into ART cycle and advanced procedure. So according to this meta-analysis, it was done long back in 2017 and then was revised in 2019. And they had seen that premature luteinization and LH surge was prevented, but LBR and CPR was not corrected much. But when they did the sub-meta-analysis of only those articles which were RCTs and reached to a statistical significance, there was very good pregnancy rate, best pregnancy rates when antagonists were administered in this cycle. And as my panelist rightly said, that it should be started somewhere around 13 to 14 mm and should be continued till the day of trigger, and it should be given preferably in the morning and not half dose, 1 dose or something like that. And so these are the rates. And I think with this, we'll come to our
one point I would like to add, that in this Bahadur study, what he has done, that when you get a 1 follicle which is growing and 2 or 3 follicles are smaller in size, then they have used an antagonist, because instead of 1 follicle, if you get 2 to 3 follicles at the time of trigger, it gives a better pregnancy rate. So one of the use of antagonist is to accumulate 2 to 3 follicles, and then you give a trigger, it will give a good pregnancy. That is the same study by Bahadur.
Yes, sir. The same, it has said that bifollicular development along with antagonist is supposed to give the best result for any gonadotropin IUI cycle. Regarding cancellation, we all know that if there is no recruitment, more than 3 or 4 follicles with E2 levels and all. So I think our panelists, my panelists, they agree with these facts. So we'll
Yes.
move ahead towards our ART cycles. So, and pregnancy is always compromised when there is insulin resistance or obesity with insulin resistance in PCOS, but not otherwise obese people. They don't get compromised IUI pregnancy. That is an important point I wanted to bring. So here comes my next question, which was like we were waiting for. So as I was asking in IUI cycle also, sir, the same question I am repeating from all of you. Do the various isoforms of FSH matter while deciding your stimulation protocol? I'll start with Dr. Nimish, and we'll just keep it in 1 or 2 liners so that we can have further discussion on protocols and rest of the things.
Basically, when we started IVF long back in very early 90s, you see, there was no recombinant FSH. So we have quite a long experience by using urinary FSH only. So basically, we did get pregnancies even at those times, and it was not that urinary FSH did not give us pregnancy. The isoform of FSH came out little later, much later, about almost in late 90s and then in the early 2000s, that we got the recombinant form, and the recombinant form was genetically engineered. It was not from the urine samples that menopausal urine samples that these FSH or the LH or the HMG was isolated. It was genetically engineered, and the FSH that was recombinant was used for getting into these type of patients where they would not respond, or the quality of follicles which would really matter. Now, as far as the quality is concerned, it's the ultrasound scanning that would show us only the imaging part, but only when you actually retrieve that follicle and for the egg from the follicle, the oocyte, and study it, you would get to know the quality. And of course, the fertilization and the embryo development later on. So with recombinant, there have been a lot of there are lots of studies, and the Cochrane data and everything is there. But in my experience, I have seen that the effect is nearly the same, and urinary FSH is equal and as competent as the isoform. In rarest of the rare cases where there have been a lot of resistant cases who have not succeeded in the past with failed cycles, we may try recombinant if that would really matter. But that's my opinion. I would like the opinion
Yes,
on
sir.
the other.
So it is, your choice is FSH urinary. Literature and evidences are almost equal in terms of live birth rate and clinical pregnancy rate.
Yes,
Here we are
yes.
talking about individualization and personal preferences from all of you, as you can make a difference in our learning. So Dr. Nagori, what is your preference? As you've already stated some, but we would like to listen to it again.
If you consider the specific activity, then that of the urinary FSH is 2000. If you consider the highly purified HMG, then it is 4000. If you consider highly purified FSH, then it is 9000. And if you consider recombinant FSH, then it is 10,000. So more or less recombinant FSH and highly purified FSH are more or less the same bioactivity. So if you use either of one, then it is very good. Second, I would like to tell that urinary gonadotropins are prepared from the menopausal urine, where the FSH is having the least bioactivity, while the recombinant FSH, which is cloned from which is prepared from a Chinese larva, which is cloned in such a way that it mimics peri-ovulatory FSH. If you consider FSH after menstruation is having least bioactivity, but the FSH which is secreted during the peri-ovulatory period is having the highest bioactivity. So the recombinant FSH is having the highest bioactivity, and that is why the dose required of recombinant FSH is less than the urinary. Now you consider the dose, and then you consider the dose of urinary, more or less the cost will come as the same. And that is why we prefer either highly purified FSH or the recombinant FSH for majority of the patients.
You are absolutely right. And the reason why we have switched over, one reason was paucity of the samples from which we are just getting these gonadotropins, and second, side effects because of impurities. So that was the reason of development of
And
these.
one more thing,
Yes.
we can inject subcutaneously, this less pain.
Batch
Patients
to
that
batch variability, accessibility, dose adjustment, all these are few factors which add to your choice, choosing your gonadotropin. Dr. Sejal, do you want to add something?
No, the same as the Nagori sir said.
What is your preference? HMG, FSH, if urinary or recombinant?
For IVF cycle, recombinant or highly purified only. Only in very like more than 35 years of age and poor ovarian reserve, we use HMG. Otherwise, preferentially, it is recombinant or the highly purified.
So here,
when we talk of highly purified, what do we really mean by high purification? It is not genetically engineered.
Grade and extent of purification increases with the I think so.
Purity will be very less and LH active will be almost negligible in HP.
No, but that is a matter of purification. It is still the source is still urinary. It is not genetically engineered.
Urinary, but remaining impurity, prion.
Yeah. So we are striking a balance here.
Slightly higher dose. That is the only thing, because the bioactivity is considered 9,000 units, while with the recombinant it is 10,000 units in the literature. So that's why you require slightly higher dose of highly purified FSH.
Highly purified. So here one question comes to my mind, like there are two different distinct kind of protocol being followed by Americans and Europeans when it comes to ART practice. Like our American counterparts, they are mixing HMG along with their recombinant FSH from the beginning of the cycle, while Europeans, they believe in continuing one product. So what is your choice?
Ma'am, I would like to use one product only. This mixing, and that is to having that stock, and that is also another issue. So better to follow the only one product.
So
Madam, I would like
go for FSH or HMG. You don't give FSH plus HMG, or
I add HMG when I add HMG in like after 5 days of the stimulation cycle when we want. Yeah, that for that only. We don't start with the beginning of mixture.
It's right, Sejal. But what I would like to emphasize that HMG is always added after day 5 or day 6, because unless the follicle is 10 millimeter, the LH receptors have not developed. So even if you give LH from very first day, that LH is useless, and LH is not going to work on this patient. So in the initial, you always require an FSH, which will produce the LH receptors. And then if you add an LH, it will be much more beneficial.
So Dr. Patel and Dr. Shell.
Normally, we consist with the normally I believe more in recombinant, and we'll start with the recombinant. We normally use in 95% we use antagonist cycle. In a few cases we add LH after starting antagonist. Those who have poor slow responder or hypo responder, old age, and ovarian disease with less, previously patient having less egg retriever and less embryo formation. In that case, we suspect any FHH-LH receptor polymorphism. In that case, we add the LH. That is a purely few indication to add the LH after stimulation, after 5 days of the stimulation of any recombinant, when we start the antagonist.
So I just wanted to add, I completely agree with Dr. Nagori. I think we have lost Dr. Nimish.
Yeah, no, I'm here.
Yes, sir. Okay. Do you want to add something?
What has happened? It's my video has closed down. Just a minute.
Okay.
Can you see me now?
No, sir.
Yeah, you can see me. Yeah, it got the video got stopped. Anyway, can you hear me?
Yes, sir.
Yes, yes.
Yeah, right. So basically, you see, the first thing is when I meant urinary, I also meant that highly purified, because nowadays
Yes,
we
yes.
don't use the those kind of urinaries that were used 20 years ago.
Yes, sir. Yes.
We almost aim for HP, as we call it, highly pure, and I very much agree with using highly pure gonadotrophins, which are in the clinical use. And at the same time, basically we between recombinant, again I would like to come back on this. Recombinant we tried in several trials, and we have found that you get good number of follicles. The follicles appear beautiful on the ultrasound scan when you compare them maybe with the highly pure stimulation, but at the same time when you retrieve them and when you actually fertilize them, there is no difference in the pregnancy rate, even if you have used recombinant or if you have used highly pure. That is my personal experience. And I would like to know from other colleagues of mine who would like to comment on this. But pregnancy rates have not changed using recombinant, or getting
all
more
the
embryos,
literature-
as for that
yes,
matter.
all the literature have confirmed that pregnancy rate is not different, though as Dr. Nagori has rightly said that the doses become bit increased when we are using highly purified urinary products. So I agree to this thing that Dr. Nagori, that this FSH, you don't require that baseline LH activity, and it can break the ceiling and before 10 millimeter. But that is a very factor which is going against recombinant FSH. Because of getting such a high activity, it is creating a follicular recruitment in a way that it is causing supraphysiological level, and which is leading to premature luteinization and LH surge. And that is the reason why people are looking for alternatives like HMG to begin with their cycles. I think that gives, and that is one very important and way of decreasing the incidence of ovarian hyperstimulation, which are likely to be more with our recombinant preparations. So with this, this is as we have already discussed that all these products, they work almost same. So my next questions, like there are few things which work really nice when you start our ovarian stimulation, but there are few factors which really hinder our way of stimulation. So whenever you are deciding your ovulation stimulation protocol, what are the things you really take into consideration? Like few people just go by AMH-AFC, few people also include BMI, age, and few people, they also look into previous stimulation outcome or response. So what is my panelist's individual view on this in very quick lines?
We take into consideration, of course, the AMH, because now AMH has come into very much active picture, and it would not be fair to ignore AMH levels, though not all AMH per se will be 100% accurate. Also, that's what I have seen, where sometimes with low AMH also we do get response. So, but that is in only 5 to 10%. Of course, antral follicle count, as you have mentioned, it's very, very important. We should have minimum 4 to 5 antral follicles per ovary so that we can initiate the stimulation. BMI is extremely important because basal, the body mass index is an important parameter of the dosage that will be required. And generally, patients with normal BMI, they respond better than those with higher BMI. Age is also a factor. Age is also a factor because age greater than 35, you usually land up giving little higher dose because ovaries are becoming more and more resistant. And of course, the previous stimulation outcome is also important. Sometimes you don't get access to that because the patient doesn't give history or doesn't have the past records. But if we can get it, it's very, very important because that will help us to improvise on our own stimulation protocol.
Okay, Nagori sir, AMC versus AFC versus AMH. For
We
you.
do always AFC, we never do AMH for any patient. We go for our scoring system, and there are more than 50 references in the literature that the AFC is equivalent to AMH. And second thing, actual AFC will give you an idea how many follicles you are going to retrieve. almost about 60% of the AFC will be the number of the follicles you will be getting by and large. So that is why we rely only on AFC and our scoring system only. We never go for AMH on any patient.
Okay, sir. Something is going wrong. And protocol, how do you decide? As per literature, if we want to revise AMH and AFC, they work hand in hand. Both are equally good. Sir, Dr. Sejal, do you want to add some point here?
Ma'am, these are the like major deciding factors for choosing the protocols, but like other minor factors may influence the comorbid disease and the cycle length and the how much time patient has with us, like freezing or non-freezing of the cycle. So I think these are the main factors to decide the protocols. So mainly they maybe the like poor responder, normal responder, or high responder. According to that, we decide the majorly decide on the protocol.
Okay, so if we review the literature, the same thing happens as I was telling. Nobody can take age and BMI as primary factor in deciding the dose. They can help, but they cannot be used exclusively when we are talking about the quantity of oocytes we are going to get or we are thinking about getting. But yes, AFC and AMH, they function independently, and people like Dr. Nagori, who are expert, like most of our ART specialists, they believe in on their own hands, looking at those ovaries and finding the number of recruitable follicles is always better for us than going for AMH, as there is not a kind of uniformity and different criterias are being used. So that is the reason why we don't do it. So that's what our literature also reflects. So in this era of like almost all of us have just switched over to antagonist cycle now. Like I am doing 100% antagonist cycle, which is it has become a standard of care. Now I want to know what are those indications where you are using long agonist protocol. Yes, sir, Dr. Nagori.
Two common indications at present. One is endometriosis, and second is those who want to do a batch IVF.
Okay,
for these people are using the long protocol. And second is an endometriosis where you may have to go for a down regulation. Then you can use the agonist protocol.
Yes, sir. And Dr. Sejal, do you want to add something? What is
only in antagonist, like I would the patient, those who want to like have done the fresh embryo transfer in that particular cycle, I would choose rather long protocol than the antagonist protocol. Suppose the overseas patient have come for only for 1.5 months or so, and for that only cycle we had to have done the transfer, then I would prefer long protocol over antagonist.
Okay, Dr. Nimish.
You can do a fresh transfer with antagonist protocol.
I know, sir, but somehow like for
result
the
is
yeah, so for
long
somehow for considering the results, fresh transfer results are better with the long agonist protocol.
Agreed, definitely. We are facing a lot of failure in fresh transfer, and that is one of the reasons why all of us have switched to almost freeze all. Dr. Nimish, what is your what are the places where you choose long agonist protocol? How are your cycles planned?
I think more or less what everybody has said, basically, but in certain cases of PCOS, I feel that if you start down regulation in the earlier cycle, you have better control on the follicles, because as soon as you start, I mean, you have a down regulation in the previous secretory phase, and then when the actual cycle starts, you already have established a control on the pituitary.
Not dare to do long agonist in PCOS, sir.
Yeah. And then you see because what happens that if in a case of PCO, if you start stimulating only with FSH, you may still have problems with the follicular size later on, and then when you by the time you start your antagonist, you already have irregular follicle size, and that's what you don't want, because you don't want eggs at a different level of maturity when you are going for pickup. So it's in some of these cases we do use agonist protocols as well.
Yes, sir, agreed. There are people, experts who use long agonist protocol for PCOS, but personally, I would not dare to, because for me, 3 cohort do not make any difference. But if this patient needs a
You have to
very hyperstimulation, I will not forgive myself. And second thing regarding endometriosis, sir, nowadays I am doing antagonist protocol, collecting the oocytes, and then we are using agonist and doing FETs. That is the way we have been doing. So agonist, and I really want to learn agonist protocol because it has really been ages since my fellowship day. I did not use agonist cycle. Dr. R.G. Patel, do you want to add?
Yes, yes, same. Almost near to 100% we are using antagonist in any most. Yeah, antagonist, freeze-all, mostly no fresh transfer.
Yes.
Yeah, almost.
So, yes. So here we come to our favorite topic. So it is a rapid fire, and I'll ask one question each. FSH or HMG, Sir Nagori?
FSH.
Antagonist on day 5, 6 or at 14 mm Sejal?
5, 6.
So what is your preference, 5 or 6?
6. Day 6.
Of stimulation or of cycle?
Pardon?
Is it day of stimulation?
Day 6 of injection is cycle.
Day 6 stimulation. Okay.
Stimulation.
Okay. And agonist trigger or dual trigger, Dr. Nimish?
I would go for agonist trigger, not dual trigger. Dual trigger, if you give dual trigger, you have to definitely give luteal phase support as well. So I would avoid
That will lead to my next question, sir. Dr. Patel, freeze all or fresh transfer?
Freeze all.
So there is no question of giving proper support, agonist, and this is the.
Here, can I just give an opinion on freeze all?
Yes, sir.
Because I differ from that part, because see, fresh transfers, there have been a lot of studies for fresh transfers versus freeze all, and these pregnancies have been followed up. And a lot of these pregnancies later on, when they're in the antenatal period, when they progress to first, second, third trimester, there is a higher risk found of preeclampsia and morbidity in frozen embryo transfers compared to fresh ones. So basically, we should not be, we should not make it 100%. Where it is necessary, where you feel there is only, and there is no other option, one may go for freeze frozen embryo transfers. But as far as possible, if you can do a fresh one, it's still preferable, according to me. That's my personal opinion.
Yes, sir. PCOS is the only condition where, in spite of all these comorbidities and things coming into, they are promoting that if possible, you should go for freeze all. Dr. Nagori, your quick opinion on this.
We always go for freeze all cycles, but I would like to comment on agonist trigger or the dual trigger.
Yes,
those
sir.
who want to do a fresh transfer,
Yes,
or
sir.
those patients who have taken OC pills previously, then in these patients, when you give agonist trigger, the LH surge may not occur in all the patients.
Yes,
If it is less than 13 international unit, then you will get an empty follicle syndrome. Actually, it is not an empty follicle syndrome, but you will not get a single OVA if the LH surge has not occurred because of an agonist trigger. So that is why you should combine 1000 units of HCG, which will complete the meiosis. And when you do a pickup, you get all the eggs. Otherwise, and that has given almost 52% pregnancy rate with the fresh transfer. So those who are doing a fresh transfer in a PCO, then instead of agonist trigger alone, you may give about 1000 units of HCG, and then you can get a good pregnancy rate. Or even those who want to freeze also, then also the 1000 units will work very much, because there are some cases where the trigger may not occur. So we always prefer agonist trigger and combined with 1000 units of HCG.
Rightly say, one more I want to comment, because same rightly say, to avoid any less follicle or empty follicle in case of agonist triggering, in case of PCOD or like many follicle, like previous history of OC pill, or sometime patient may have taken antagonist depot for any reason. So to LH on the day 1 of the stimulation, LH level, if it is less, then chances of less LH surge and less follicle will be there. So always keep in mind to do LH level if patient having history of OCP for 1 or 2 months. So always do LH level. LH level is on lower side. You can add some 1000 or 2000 HCG with the agonist to avoid any empty follicle.
Okay, so I'll start from the first question is FSH versus HMG. As we have already discussed that Megaset trial and Merit trial, they are looking into HMG as a substitute for FSH to decrease the number of follicles in these PCOS patients, to decrease the chances of OHSS, and along with that, they found better live birth rate, clinical pregnancy rate, lesser miscarriage rate, even in frozen embryo transfer cycle. Regarding antagonist introduction, fixed protocol works better, I think, for these PCOS patients because they are prone for premature utilization and things like that. Agonist trigger as much as possible. I have not seen if the quality of these agonists is good and it is not an intrinsic factor. We always get oocyte. It is not like it gives empty follicle. As Dr. Nagori said, I believe in dual trigger, but not in every PCOS, and that comes, it's got a long learning curve and you have to learn it before using it. For all practical purposes, agonist trigger, agonist trigger, agonist trigger, and freeze all. And you have benefit of getting FSH surge along with LS surge when you are using dual trigger. You are not going to lose anything as you are going to freeze it all. But I'll again say that please do it when you are really experienced in doing. Until then, you freeze all and go for agonist cycle. So here is the next question. That is a confusion. Like for poor responders, we have Bologna criteria to define. There is no clear-cut definition of hyper responder, and every hyper responder does not become a OHSS threat. So what is my panelist criteria of defining hyper responder?
We always go for a hyper. We always go for enteral follicle count. When the enteral follicle count is high on both sides, or if you see our particularly when the score is not 20, then we always consider it as a
Yeah, but sometimes what happens, these are unexpected hyper responders which are visible when we start our stimulation. So there it is very difficult. You are right that if we have already done our baseline AFC, we would be able to differentiate between polycystic ovarian syndrome and the unexpected hyperresponder. There is no clear-cut definition, sir. How much do you take cutoff as a hyperresponder?
Ma'am, approximately 10 to 15 follicle total, we consider it as an average response. So about that, we can do.
And so there was a very interesting paper by Papanicolo, and he has taken anything like up to 14 follicles of around 11 mm. That is okay. If it goes beyond, that comes under hyperresponder. The differentiation is important because every hyperresponder is not PCOS, and because of their idiosyncrasy, PCOS are really prone to get OHSS. Every hyperresponder does not get OHSS. So anyone who's having up to 14 follicles, when you have started your stimulation, you are seeing that patient on day 11 or 12. And these are the candidates where if you want to do fresh transfer, or if you want to include dual trigger or SCG, you can add. That was the message which I wanted to give, that every hyper responder is not OHSS prone. So now a bit masala and chutney. Like all these days, even during lockdown, patients are so much in hurry. Like every day 2 of cycle, they'll call, madam, ab kab se shuru karenge, ab lockdown kab khatam nahi ho raha hai types. So sir, how do you convince your patients for these kind of pre-optimization of the cycles, or do you believe even in it, doing pre-optimization of your cycle before starting your ovulation stimulation?
If you ask the patient to lose the weight, you are helping your neighbors. So don't wait for that. You should treat the
That is,
patient the
yes.
way in which the patient has come. Because she must be also knowing that she has got the increased weight. This is one of the reasons. But she would have reduced by this time before coming to us. So by just telling that and discussing with the patient for weight reductions, they are not going to obey you at all. So that's why I personally feel that you must tell them that this is useful as far as your conception is concerned, but we should not wait for the treatment
To start. So you start your stimulation the moment patient is ready and she gets her period. Sejal, do you believe in pre-stimulation optimization in terms of their
Yeah.
vitamin intake, weight reduction, or anything as per their reports?
Ma'am, if she is really very young patient and with a good reserve, I would definitely encourage her to reduce some weight before getting pregnancy. But as sir said, we would not wait extensively to like until and unless you lose the weight, we will not start the treatment. It would not be like that. So simultaneously, we make them sensitized towards the benefits of reducing weight and the prevention of complication during the pregnancy time. So that would motivate them. At least even 5-6 kg also they reduce from like even 10% of their body weight would be very effective.
Dr. Nimish, what is your take on this question?
If there is, I mean, if the patient is too grossly obese, we would definitely advise them weight reduction, because even if she conceives later on, there are going to be problems with the pregnancy itself. So, but basically, as we find in our clinical scenario, if a patient is young and she has time, I mean, if she has good time to reduce weight, she should. But at the same time, sometimes the age is also a factor. And say if she's almost 35 or she's more than, I mean, she has crossed that age, and still if she's obese, then one cannot wait for too long because of the ovarian reserve issues. So we have to balance our clinical decisions at that time.
Do you want to add something or do you agree with them?
This question is to Dr. Patel.
Yes, not to wait too much. Just tell them and start the stimulation.
So all my panelists, they agree to the fact that pre-optimization is good, but we cannot wait for long, as it's patient's prerogative whether they are going to follow, otherwise they fall into neighbor's lap. So, और सास जी कहेंगी कि मोटे होने पे क्या हमें बच्चा नहीं हुआ था जो आप इतना टाइम लगा रहे हो हमारी बहू को बच्चा करने में. So all these factors together, but we should always take this opportunity to tell that this optimization is going a long way in terms of healthy baby and healthy mother, as our aim is not only to make them pregnant, but along with that, we have to deliver a healthy baby to a healthy mom. So now we have come to the question of these unexpected poor responders or Poseidon group 1, 2, 3, 4. So I just wanted to know, how do you tackle? Do you put a blanket kind of treatment for everyone in terms of protocols, in terms of gonadotropin dose? Yeah, you individualize these different groups differently, and what are those criteria and protocols you are using? I'll start with Dr. Nagori.
See, if you consider Poseidon group 1 and 2, in both these conditions, you are expecting a good number of eggs. But in spite of that, if you don't get in your previous cycle, then these are the right candidates where you would like to add an LH to both these groups. So group 1 and 2, less than 35, more than 35, but in spite of the age, both are having a good AFC, both are having the good AMH. And in spite of that, if you're according to your expectations, if you don't get the number of eggs, then these are the right candidates where the LH is to be added to this patient. Otherwise, less than 35 years of age, as well as those patients who are more than 35, they are definitely the candidates. But with a good ovarian reserve, there is no point in adding an LH unless the response is poor.
So, sir, my main question, the reason of asking this question was like the people they are talking, it has almost cleared that quantitatively, the greater the number of oocytes, we create more embryos and the chances of pregnancies are better with more embryos. So in who are those particular groups where you do increase your dose, or just like international forums, they keep talking about 150 to 225, you keep doing the same thing?
See, increasing the dose does not going to give you the more number of eggs and more number of embryos. Maximum dose that has been recommended in literature is 300 international units. More than 300 units is not accepted. And if you consider a poor reserve patient, then the 300, 450 or 600, the pregnancy rates are the same. And that is why people never go beyond 300 units of FSH in a responding patient.
So, conventional versus mild stimulation for these, especially older patients, there are two groups: poor ovarian response and unexpected poor ovarian response.
There are equal number of papers. If you consider the Polizos recent paper which has come in 2020, he says that the mild stimulation has no much role.
No use.
To a conventional stimulation to the patient. So there is only a very small subgroup like more than 35 years of age, less than 5, and AMH less than 1.2. These are the cases where you may go for the mild stimulation. Otherwise, they never recommend the mild stimulation protocol because the number of eggs retrieved are quite less and the pregnancy rates are also very low.
Yes, sir. Dr. Sejal, what is your take? Like I have gone up to 450 in few of my unexpected poor responders and I got good yield. So I just wanted to know individual opinion. Sejal, what is your opinion? What is your
my highest dose is
mild stimulation protocols at all?
No, I do not very keen towards the mild stimulation. And maximum dose I use for very poor ovarian reserve is 450, not more than that. It never give
you also use 450 sometimes.
Yes,
you
sometimes
around 300, 225 to 300, but you go up to 450. Dr. Nimish?
Yes, I think it's the same standard or everywhere. Rarely one can go beyond 450 because if you don't get response beyond that, you're not going to get it anyway. Basically, I think that is the ceiling which one should consider. And there's no point in flogging a tired horse, as they say.
Reserve and response.
Dr. Patel.
Madam,
Yeah.
I would like to add
No,
yes, sir.
Poor remain poor. Whatever you do, they poor. We have to identify. If needed, we can give 1 or 2 month pre-treatment like DHEAS or testosterone or coenzyme Q or any omega-3 fatty acid, whatever you can do. But main is stimulation. When there is a young and having expected AMH and FSH, you always start with the FSH only. But after 6 days of follow-up, monitoring, when you expect there is low responder and hypo responder, in that case, you need to add LH. That is young with normal reserve. Second, old age with normal reserve. Because of aging effect, we may need to add LH from the day 1 of the stimulation.
Yes.
Madam,
Group 3 Nagori wants to add something, yeah.
Yeah, group 3, young but decrease ovarian reserve, start LH from day 1, but on a small 75. Old age, already reserve is less, you can add more 150 LH with the day 1 of the stimulation with the FSH. Highest dose may be around 350 up to 450.
Okay.
Madam, I would like to tell one thing, that there is a difference between the reserve and the response.
Yes, sir. That's what I wanted to.
So if the reserve is poor, whatever amount of gonadotropins are given, you are not going to get the eggs.
Absolutely.
When it is a poor response, then
and their individualization will work.
So counseling is very important.
Yes, and this Poseidon picture helps you in counseling these patients regarding these things and individualizing your treatment.
Yeah, young not responding, that may be due to FHH, LS polymorphism. But those who have already we are knowing less reserve and counsel them may need dual stimulation.
Okay, so
Alright.
that brings my next question of
scripted
dual
it.
stimulation. How many of you are following dual stimulation protocol, and who are those patients where you are following? Very quickly.
I am doing dual stimulation in many cases. Those who are already failed and MAH is less by AFC, by AMH, by short cycle, by previous response. So we have to counsel them, and we are doing dual stimulation.
What is your protocol? Sir? How are you doing it?
For 4 days.
We will start with the 450 unit with the 150 HMG and maybe Lewis, that recombinant LH. In those, we are already knowing to a responder, already known. Previous issue also. So start with the 2 to 5 recombinant FHS with 150 LH recombinant. Both recombinant FHH and LH.
Yes, sir.
And monitor it and go for recurring. And if you got enough egg, enough embryo in a first cycle, maybe around 3-4, then not to do second stimulation. If you got 1 or 2 only and only day 3, then we will counsel for the second stimulation after the first period.
Okay.
Previously, we have done also in the same cycle, that is Shanghai protocol.
You are not doing it like a dual stimulation, you are doing twice.
Twice, yes, twice.
Dr. Nagori.
Yeah, that is, if it is in the same cycle, then it will be the Shanghai protocol in the same cycle.
Yeah.
So clomiphene citrate, letrozole.
2 protocols, random start and dual stimulation. And what is the place of these protocols in your practice? How practical are they? And are you people following it or not?
See, the dual stimulation is required only for those patients who have a very short time. Either they are suffering from malignancy and they have to go for the chemotherapy. So you have very less time. And that is why you are picking up more number of eggs and you can have a blastocyst which can be freezed. Otherwise, if you ask personally, then I don't follow the dual stimulation, because by 15 days is not going to decrease the number of eggs which are present inside. So I don't know why people are going for dual stimulation. After 15 days, once again you can see an AFC and you can stimulate. And second thing, when that stimulation, you have got a chance to do a fresh transfer. If you do a dual stimulation, you are definitely have to freeze all the embryos and then you have to transfer. So this is only for those cases where you have very less time for collecting the number of eggs, where the woman has to go for the chemotherapy or suffering from this.
Regarding both the protocols, yes.
Those who have very less time, like abroad patients.
Add something? Are you doing dual stimulation or random start protocol? If yes,
No. We normally start the conventional protocol. No dual stimulation.
And Dr.
I don't believe in dual stimulation. If you ask me, I still don't believe in it.
Yes, sir. So majority of the ART consultants before also, and as you panel of specialists, everybody is of opinion that this is not going to change. Her ovarian reserve is not going to change.
Just listen me. Just listen 1 minute. There is a 2 things. One is dual stimulation, that is in a same cycle.
Yes,
we is a double stimulation.
We are talking
we do double stimulation. Previously, we are doing dual stimulation in a few cases. Then we have stopped it. Now we are doing double stimulation.
Yes. So the only reason why people do dual stimulation is to chase the second wave of follicle, which is being left, which was 12, 13 at the time when you were doing the pickup, and every follicle matters for a lady who is Poseidon group more than 35 years and with less than 1.2 nanogram of AMH. These embryos, they'll make the difference, even 1 or 2 oocytes for embryo pooling. And besides that, as Dr. Nagori has rightly stated, until unless there is an emergency like fertility preservation, we have to start this random start and dual stimulation. There is no such regular recommendation for these protocols to be followed in our regular practice. Yes.
Sometimes abroad patient have less time. In few cases that we can do it.
Yes,
They-
wherever you have time constraint, you can start and freeze all. The first and foremost prerequisite is you have to freeze all, you cannot do the transfer. And the evidences also speak in same language. These are not recommended on regular basis. So the most controversial question where evidence is really mixed or against using pre-treatment. How many of you believe in COC pill pre-treatment? Just yes or no?
No.
No.
Everybody, you do?
Yeah, actually I do to make sure that there is no residual follicle or cyst for the
Yes, we are talking about that sigil. So you are using COC. Dr. Patel,
No.
progesterone?
No.
Everybody?
No.
Estradiol valerate?
Yes.
Yes.
Yes, I am doing to synchronize the follicle.
Yes.
Yes, Dr. Nimish, I cannot see your complete face, so I'm not able to understand what are you saying.
No, I can. Can you hear me?
Yes, I can.
Right. Yes, we do use estradiol valerate and not much estrogens.
So yeah, and androgens?
It means not much androgens, I would say. Estradiol valerate, yes.
Okay. So majority of us are using estradiol valerate to synchronize our cycles. As per literature, COC is definitely no if we are following antagonist cycle, agonist, batching. So only indication where pre-treatment with progesterone and estradiol is recommended, that is batching and synchronizing for that. And that is the only thing where we are using pre-treatment. Otherwise, it's your individual choice. Long time back when we were doing batches, we were keeping our patient right, left, centered on these COC pills. We never felt any difference in terms of pregnancy rates. But either we were very young, those batches were very small. I don't know, but I could never make it out how OC pills has deteriorated things like that, and it has become something which nobody is using. So now
I think Seema, we will have to now wind up because we are crossing the time.
that's my last question. It is,
yeah.
How do you look at progesterone prime stimulation? Because it is a new kid on the block, not very new, but young kid on the block. So how many people are using it and in what indication? That's my last question, sir, and we are winding up. Progesterone prime stimulation, how many of you are using and what are the indication where you are using this?
Perhaps.
Dr. Nagori, I can't hear you clearly.
We are not using. Perhaps we may avoid antagonist in future and we can give the progesterone from day 6, which will be cheaper to the patient. But still we are waiting for the more papers to come before we actually use it on our private patient.
Region?
No, ma'am, we are not using.
Nimish?
Same.
No.
And Dr. Patel?
Same. Yes.
Let me tell you, I am using it for last 2 years for my hyper-responder PCOS patients and people who cannot afford it. And I'm getting good, excellent result. And there is no side effect I have experienced in terms of increment of doses. I'm starting Devry or medroxyprogesterone from day 2 of cycle along with my stimulation. And it goes up to the day of trigger morning or afternoon. And then you have to freeze all. That's the main prerequisite, that you cannot do fresh transfer. So it has been really helpful for people, especially donor cycle, donor programs, and hyper responders on PCOS where you have already decided that you are going to freeze all. So progesterone prime stimulation, yes, it needs more literature to come out, but many of us are practicing and are very happy about it. But it cannot be used in each and every patient. You have to individualize it. So with this, I would really thank my esteemed panelists. You all were awesome. And there were so many things to learn from all of you. And I'm really sorry it took me so long because of those technical glitches, but it was really interesting interacting with each of you. Thank you so much.
Thank you so much, ma'am. It was really very interactive, very informative, and we
Yes,
thoroughly
sir.
enjoyed.
We really enjoyed it.
A lot.
I hope I
Tilak sir.
could make up for that delay which I had in the
Yeah.
Well,
Bye
Are
bye.
we
sir.
offline now? Are we offline?
Thank you so much, Dr. Seema.
Thank
So
That
I would
was
just like to.
that was because of network failure.
Right.
Raining, no, and
Right.
I was calling my son. I was calling you guys that what's happening.
Right. It happens. It happens. It happens sometimes.
And what has
Fine.
happened to Dr. Pawan? Why has he not joined us?
Dr. Pawan is here.
But he wasn't listening to his video was off. He wasn't answering my questions.
Must be some issue. I can see Dr.
Anyway,
Pawan.
Are we
thanks everybody. Shall we can close now, and I thank you all for having participated so well. We really
Right.
enjoyed it, and we have a very good feedback from Hetal Moda, who is our EC member. She has appreciated it as an excellent discussion from as a member who has been listening to this program. And I thank you all, Dr. Sejal Nayak, Dr. Seema, Dr. Even Komal, for having integrated the whole program so well. And
Thank you
of
so
course,
much,
Dr.
Doctor.
Chaitanya Nagori and Dr. Patel, who were with us. So it has been a great discussion. And we stop here. It has been a really
Dr. Seema would like to say.
I have to speak because I lost connectivity in the beginning. I would like to thank Gujarat chapter of ISAR and Dr. Nimish Shettle, along with Central ISAR, Dr. Prakash Trivedi and Dr. Kedar Ganla for this opportunity, and our partners for giving this platform to this academic bonanza. Thank you so much.
Thank you, Dr. Seema. Thank you. It was same here. And before just ending the session, I just would like to play a small video for one of our brand. So with your permission, Dr. Nimish, can I play that?
Yes. Yes, thank you. Thanks a lot.
Thank you so much, doctor. So I would just play the video.
Dydrofem, faith delivered.
Thank you very much. Thank you very much.
Dydrofem is bioequivalent to Innovator at 25% lower cost. It is made using complex photon bombardment and purification process. Dydrofem's structure is exactly like the reference dydrogesterone structure. This brand is brought to you by Dr. Mukund Gurjar, rated as one of the top 75 scientists in India by CSIR. Dydrofem is brought to you by Encure, India's #1 company in women's health, most trusted by gynecologists. It is for patients with recurrent pregnancy loss, history of miscarriage, and defective luteal phase. It has better potency, bioavailability, and tolerability than progesterone. Dydrofem, Emcure's dydrogesterone, proud to be made in India.
Thank you so much for patience listening.
Thank you. Thanks a lot.
I'll end the meeting now. Thank you. Very nice.
Hi, Dr. Nimish. Thank you, dear.
Thank you, Seema. Thanks, everybody.
Sir, also for giving us opportunity, sir, and all the eminent panelists and respected doctor. Thank you, sir.
I really enjoyed interacting with all the eminent people. They were awesome.
Thanks to the whole team.
Yes, sir.
Yes.
Thanks to the whole team for having organized such a beautiful program.
Yes,
Kishore
sir.
and everyone, including
I'm
Kedar,
very
who is not
excited,
around.
and I hope
But it was a great meeting.
I hope
Thank
Dr. Dharmesh parents are better. His father is not well.
Mother.
His mother is not.
So just convey my best regards and a message. She's in our prayers to get well
Sure.
soon.
Sure, madam.
I'll end the meeting for all. Thank you. Thank you, everyone.
Thank you.